So you thinking like 9:30, or are you thinking even sooner than that? So normally it would be. So would we take a break and then come back?
I think we'll be on there. I bet you we're here by 9. Oh, wait, 9:30. Okay, wait, yeah. It's going to be quick. It's not going to take 15 minutes. 10 minutes. If we're on time, 15. This whole thing will be 30 to 45 minutes.
Okay.
Okay, we're going to call this meeting to order. It's the March 20th, 2019 annual work session meeting of the Mojave County Employee Benefit Trust Fund Board of Trustees. We are all here, I believe, except for Sam Scamardo, who's en route, and Artie Loxman, who cannot make it today. Is that correct? Correct. Okay. So we'll start with the official business. Do we start with the pledge? Do we usually do that? I don't even remember.
It's not agendized for that.
Okay. So we're going to start the meeting, and I'm going to open the call to public. Is there anyone who would like to address this Board of Trustees about any issue that's not on our agenda?
That's not agendized for today.
It says call to public,
Not for today.
March 20th. It says March 22 EBT meeting agenda items called to, on the first page. Is that okay?
That's not what's in my book, so sorry.
Well, I want to make sure wait, excuse us.
I'm all right, because I know some things were taken and given back, and I don't know if they made it into my book. Okay, let me just make sure. Yeah, make sure I got the latest and greatest,
Yep, you got the right one. We have the wrong one.
everyone has the wrong agenda, except me. How do you want to do this, Jimmy? Everyone's
Go with what you have, she's gonna go find some.
okay.
All right, back to the call to public. If anyone would like to address this board about anything that's not on the agenda, please come forward. Hearing going once, going twice. We're going to close the call to public. I'm going to call on, before we get started, there is a little change to the agendas that you don't have yet, and that is we're going to just flip item 6 and item 8 the dental claims review, and the diabetes program overview. We'll be hearing about the diabetes program first, number 6, but we'll talk about that more when we get to it. So I'll turn this over to Erin Collins for opening remarks, introductions, and agenda review.
Thank you, Madam Chair and members of the Trust. For the record, my name is Aaron Collins, I'm the president of Aaron Collins Associates, and we're the consultant to the Trust. With me on my left is Jamie Merlino. Jamie is standing in today for Missy Jensen. Missy had the audacity to give birth to her first child, and Jamie has gently stepped up into the breach. And on my right is Bob Dover, and Bob is subbing in for Amanda Weaver, who is the senior group benefit specialist. She unfortunately has suffered a death in the family and is out of state. But I can assure you, if this is live streaming, she is watching with great paranoia and anticipation to make sure that everything runs smoothly. Just to overview the agenda for those in the audience and on the Trust and who may be watching, what you're doing today is we're doing the annual renewal meeting where all of the vendors will present the operating performance of the Trust for the prior 12 months. So we'll look under the hood at how the claims are running for medical, for prescription drug, for dental, and you'll actually see all of those numbers in real time. Obviously, they are de-identified to make sure that you're not seeing any names, but you're just seeing the gross dollar amounts. We'll follow up that with a report from Livongo on how the diabetes disease state management program has been running very specifically to the county. And then we will also have a wellness program review, and all of those things will kind of loop together to give you an idea how the Trust is running. And then this afternoon or late this morning, depending on how quickly we run, the Trust's actuary will be in and will review how all of those numbers translate into the rates. And as you'll notice in the transmittal memo, the spoiler alert is that we are basically coming in recommending a 0 increase. And including in that 0 increase, the staff is recommending, ECA is recommending some specific changes to the plan to enhance the mental health and substance abuse benefits to better enable us to address some of those issues. So all in all, frankly, we're expecting, Madam Chair, to be a fairly productive brief day, and in the scheme of things, happy time, because 0 increases are rarely argued against. I'd be happy to answer any questions at this point, Madam Chair.
That is certainly good news. Thank you very much. Does anybody have any questions for Erin? Before we go any further, we have this big change in where we are meeting, and I just want to explain it to people who may not know. We usually meet in some office, some meeting room somewhere, or we've even met out of this building. But about a month and a half ago, one of the supervisors put it on the agenda, wanted to see this meeting archived and recorded and live streamed so employees could watch or anyone from the public could watch. And this is the room where we can do that. And I hope that today goes as well as I believe it will be. And also, so for the trustees, when you speak, please make sure that your mic is on. So you have to, and when you don't speak, I would suggest you turn it off because it picks up everything and it goes into the record for sure. Believe me, I know that for a fact. Okay, so let's move on. And we're joined, Sam Scamardo's now here. Welcome.
Thank you very
Okay.
much. Traffic was terrible.
That's okay.
And Madam Chair, the first speaker is going to be Rick Seithamel with Meritain Health, and he'll be walking through the medical claims experience.
This is the medical claims review and overview of Aetna Network and Teladoc.
That's correct, Madam Chair.
Okay, and for Sam that just came, apparently the agenda the trustees got was incorrect, so she's giving them the new ones now. Okay. And 6 and 8 are flipped. And again, will there be presentations that we can watch in our monitors here? Is that what's going to happen? Yeah. So everyone, you're right over here is where you can see the presentations that they put up there.
All right. Good morning, Madam Chair and trustees. Thank you for having me. Again, my name is Rick Seithamel. I'm the account director over at Meritain Health. And as Erin pointed out, I will be reviewing your medical claims as well as going into detail of the Teladoc product that you have. And also I'll touch base on the Aetna wrap that you have to the Blue Cross Blue Shield primary network. I'm going to go ahead and get into my agenda here, or my presentation. I have executive summary. There's 2 pages here. Again, we just want to be brief. give you time to ask any questions. So looking at this executive summary, in the top left-hand corner, we reflect that, your average for 2018 was about 1,982 members. That is a slight decrease from the prior year, 2017. We measure against that year so we can develop some trend. And I look back at the last 4 years. When you're looking at the months, the membership with Mojave County is kind of like a roller coaster, ups and downs. But since about 2015, you've seen about a 5% decrease from then. So your membership has been going down, but your claims cost, you would think that utilization would go down as well, but you've actually seen where you've had more claims coming in. And we'll get more into that when I get into the detail. One thing to mention on this is that your average family size is 2.1. What that means is that for every employee you have on the plan, you have at least one dependent, if not more. Usually when we see the number above 2, that means that your dependents are about 50% more, they're running higher than 50% of your membership. When that happens, you kind of get into the point of adverse selection, where if you have more of the people that aren't actually your employees, they might just be on your plan, they could probably drive costs up. Fortunately, though, 2018 was a good year, and we'll see that when I go through the numbers. You have 2 plans that are offered to you. You have the EPO plan, and 81% of your population is on that plan, and then only 17% are on the high deductible health plan. It might be difficult for members to move from the EPO to the HDHP just for the fact that your accumulators are on calendar year, but you make your plan changes for July. So the interesting thing enough, though, is that as far as how much it costs the employee when they're going to the hospitals and the primary care physicians, with the EPO having a $1,000 deductible per member, and the high deductible health plan has $3,000, a family of 7 or 8 could possibly spend more on the EPO plan than they would on the HDHP, because the family out-of-pocket max is $6,000. So sometimes families need to take that in consideration if they have larger families, and that's one thing we try to encourage. You usually see where the high deductible health plan is where you try to move those members so that the plan doesn't take on as much risk, and you try to share the risk with the employees. Moving to that middle box there, again, to try to normalize the data for comparison reasons. With your membership going down, we want to do per member per month. That way you can normalize the dollar figures. You think, if your membership's going down, are my dollars going down? Well, if you actually look at the dollars compared to how many members you have, you actually still see that there's just a slight increase to your per member per month. So membership going down, but your costs, because they're kind of staying relatively the same, you're just seeing a slight increase on your per member per month. And that's largely driven by the dependents. You saw a sharp increase to their per member per month, so that's why there's just that slight increase to the overall per member per month. Interestingly enough, the per member per month on the EPO and the HDHP, as I've noted previously, is that the EPO is only $394 per member per month, and the HDHP is only $398. So they're almost identical in how much you're paying per member per month for each plan. Moving over to the employee cost share, it's at 17%. So this is how much your members are paying, and then the plan is covering the rest, the other 90 or 83%. I'm sorry. Again, this is what they pay at the hospital. So this isn't their premiums. We don't take in consideration premiums. This is just looking at, when they go to primary care physician, their emergency room, hospital stays, you're seeing 17%. And usually we'll see this range between 15 and 20% with most of our plans, and especially those that have a high deductible health plan. Those are usually closer up to the 20% because the high deductible health plans, the deductible is so high, and usually they're the out-of-pocket. Even though you have a high deductible, your out-of-pocket on most plans are even higher, but with yours, your deductible and out-of-pocket is the same number. So that's why it's not as high as we see with other plans that have a high deductible health plan. It's going down to 17%. But again, the EPO, that's averaging 16.8% that the member is actually paying out of their pocket, and your high deductible health plan is 18%. So again, the plans, when you look at them, they look like they're so different, but they're actually, when it comes to members out of pocket, they're almost paying the same. All right, looking down at the bottom left-hand corner, this is your high-cost claimants. 2.34 million were spent again in the calendar year 2018. So this is out of line of your stop loss policy, which you probably get that information as well. It's separate. But for 2018, 2.34 million were spent on your top 10 high-cost claimants. So these are members that had claims that are over $100,000 just for one member. 3 were actually repeats from 2017, but 2 of those are actually termed now. So you won't see them again in 2019. Looking down, we split it out, showing you that 5 of those top 10 were employees, and then the other 5 were spouses and dependent children. So again, going back to that point I made before with your average family size being, where over 50% of your membership is dependents, you might see where sometimes your high-cost claimants will start looking more like only 3 employees and 7 of your dependents. But fortunately here it's 50-50. Looking at your medical trends, again, like I stated, your claims are going up. They're 3.7%, even though your population, your membership is down. The plan paid is just slightly at 0.7%. Good news is your emergency room visits have gone down. We've tried to do things in the past to steer people away from emergency room, try to get them to urgent care, see their primary care physician. Steps that we took were, maybe we changed the copay on the EPO plan. Obviously, the high deductible health plan, they don't have a copay. It's everything's 100% out of their pocket before they meet their deductible. And we introduced the teledoc program in July of 2017, and we were hoping that would curb it. And I will get into detail on that teledoc and how the utilization is going on that. Another good sign is your preventative services are up 9%. So kudos to your wellness program, especially administered by ECA in their office, to get more participation. But this isn't just your on-site screenings, but it's also your members going and actually having preventative services, the immunizations and things of that such in their primary care physician setting. Looking at your average medical discount, again, Blue Cross, Blue Shield of Arizona, they have representatives that will be here. So I don't want to steer too much of their thunder. I'll let them speak to their numbers. I'll just speak to mostly the Aetna wrap. With both of them, you're getting a great average medical discount of 61.8%. Your Aetna network is actually realizing 1 to 22 ROI. So every dollar you spend, you're getting $22 back on that investment. And then what we're also seeing is that it's funny, the number of claims that went to the Aetna network, so those are the claims outside of Arizona, were almost identical to, so 2017, 1,170 claims, and in 2018, 1,172. So there were just like 2 extra claims. I don't know if it's the same person doing the same stuff. It's just really weird. But the good news is that the average cost of those claims would decrease like 50%. And so even though you had the same amount of claims that you were seeing in the Aetna network, you actually saw less charges and still the same discount. So that meant less money was being paid out. So the good news on that. Any questions before I go to the next slide?
Does anybody have any questions? Okay.
All right. So going to this next slide, excuse me, I'm going to grab some water here. Going to this next slide, a lot of these numbers, what we do to try to normalize the data again is that we'll look at incurred dates so we can get more of an apples to apples. And so we're going to remove about 3 months of claims. So that means your October, November, December claims, we remove them because of billing cycles. You might not get all of them. So what we want to do is get mature claims data. That way we can not only compare just your data to your own from the prior year, but we also want to compare you to our book of business and maybe even the full market scan so that you can actually see, I see how I'm doing. Great, we're getting a 0 for, this year because our claims are running really well, but how do we compare to the rest of Meritain's book of business or even to the healthcare industry altogether? So what we're doing is we're kind of doing that to get more of an apples. It might not be red apple to red apple, it might be red apple to green apple, but at least you're still getting there. It's not apples and oranges, okay? So looking at this information, the diagnosis, top diagnostic categories per member per month trends, these are the diagnoses that actually drive the cost of your plan. And Jamie is going to be here to speak to a lot of this as well, so I don't want to steal her thunder either. But just looking at your circulatory, you did see a large increase to that. And of course, 28% of that was because of your top high-cost claimant. So the person that you spent the most money on, number one category, it was mostly because of circulatory disease. So that's why that obviously shot up. The next one, this factors influencing health status and contact with health services. It's like, okay, what is that? That sounds a little general. Well, that's your preventative services. So you saw an increase in that, and that's a great thing, because we're hoping that they keep doing these preventative services, catch something early. It's going to avoid those hospital stays in the long term. And then of course, you did see a decrease in your musculoskeletal system. And again, I wanted to stress that this is 2018 compared to 2017. It's not your plan year, which I believe Jamie might be doing plan year to plan year. Then also looking at your claimant distribution here, I've already talked about the top 10 high-cost claimants, which that's the 1% of your population. But looking at 50,000 to the 99,000, there's another 32 members. So what you're seeing is 42 of your members, or 3% of your population, represents about 48% of your claims cost. And then if you were to go even further, you're looking, 10 to 11% represent about 77, 78% of your claims. And then for the inpatient trends and all those other categories that are down there at the bottom, I'm actually going to go into the slides to get the detail to speak to those a little bit clearer. So let me just go to that slide. Let me down to 18. And again, there's a lot of detail in here. I just didn't want to go through every slide. I just want to give you high points. All right. So here we are, inpatient admits by service type. It gives you a little bit more detail about those numbers that I had in the executive summary with your inpatient trends. You actually only saw really an increase in the paid per day. Everything else decreased. So again, since your hospital stays, with the claimants going down, your admits, even all those with people not going to the hospital, that's why you're having such a great year. Not many people are going to the hospital. They might be doing the outpatient instead of the inpatient. But we did see that there was an increase to your paid amount per day. But that's really increased. If you look at medical and see complex newborn, that went from almost $7,000 up to $128,000. So when you're looking at per day, when you have a large increase just because of a complex newborn, that's going to shoot that number up. And then also with the transplant area under surgical, you didn't have one in the prior period, and then so now you had a transplant in 2018, so that's going to shoot up your number, especially when you're dividing 132,000 or 133,000 amongst 3 days. That's going to shoot your cost per day up. So, and another one is your rehabilitation. There weren't any in 2017. You had $94,000 in 2018. So again, you didn't have them in 2017. These are your higher cost things, and so that's why your per day went up. Any questions on that before I move to the next slide? One thing I mentioned is also the 18% of these costs, the $2.2 million in your inpatient, 18% of those, again, were your high-cost claimant, the number one person. Looking at your outpatient visits by service type, mostly great news. Looking at your visits, down about 19%. Your claimants are down about 4%. But the paid per visit, again, just like the inpatient, you're seeing a 45% increase to the cost per visit. Again, why is that? Looking more into the detail, we're seeing that most of your ER costs, or most of the costs per day are driven by your ER visits. And also you had an MS patient that's driving those costs as well. So again, just those unique outliers that will just change the numbers drastically. And then, of course, speaking of ER, I have the next slide, which gets into detail about the ER, because it's not just Mojave County that's seeing it. We're seeing it everywhere, where the emergency room costs, are doubling, tripling. Utilization is going down, but the ERs, they're just starting to charge so much more to use their emergency rooms. Affordable Care Act, one theory is that your plan has always had it where you paid emergency services at the in-network level. Well, with the Affordable Care Act, all plans had to start doing that. And so you started seeing, I don't know if it's just abuse of the system, and it's a theory. It's not my theory. It's just things I hear in the news that, some of these ERs, they're outsourcing the emergency room to out-of-network physicians. Maybe it's the lack of staffing, and they don't have in-network providers. So you're just seeing where these ER costs are going up so much. Looking at the detail of your emergency room summary detail, the interesting thing is that Saturdays, usually you see the higher ER utilization is on the weekends. Saturday is your lowest day. It's very weird. Fridays and Sundays, that's about 33% of the utilization. Tuesday was right up there for some reason. I don't know what happens on Tuesdays. Is it ladies' night? I don't know. People are drinking, getting crazy, and going to the emergency room. I don't know what it is, but interesting. I just thought it was really interesting to see that Saturday was the lowest day, and you'd think that that would be the day that would be the highest, and that's what. But again, your utilization is down, so that maybe that contributes to it. Maybe you did have a lot of utilization on Saturdays, and now it's going down. So 6% of your claimants had 3 or more ER visits, which accounted for 16%. I gave you some principal diagnosis just to kind of see, what are these people going to the emergency room for? But I want to go to the next slide because this is your frequent flyers. These are the people that have had over 5 or more visits. Usually, we'll see that these are the people that are probably on, the high deductible health plan. They're like, hey, I met my deductible, my out-of-pocket, I can just go there. It's not going to cost me anything anyway. Interestingly enough, though, the person in the first spot there is actually on the EPO plan, and those diagnoses are actually something that's primary care appropriate. Like, that's something that they could just go see their primary care physician. I'd have to check with Teladoc to see if maybe it's something, but basically it's a rash that's on one of their limbs, cellulitis. There's creams, antibiotic creams, and we could always check with Teladoc, and maybe, I can't specifically reach out to members because of PHI, but maybe mention to Mojave County, we want to try to reintroduce Teladoc, remind them more. We did bring some trinkets to try to give out to employees to remind them to use Teladoc. So this would be one good reason to maybe, hopefully, that this member will see it and go, oh, maybe I can just call up Teladoc. It's only going to be a small copay of $25, and I can get the cream instead of going to the emergency room. So just one idea. And then the next slide, emergency room breakdown. This just goes to show those diagnoses that were considered emergent, preventable, avoidable. So when we're looking at those 3 categories of preventable, avoidable, primary care appropriate, or non-emergent, that was about 27% of the cost at ER, about $204,000. So again, even though utilization is going down, it's going in the right direction. This number could have been a lot more, but we are still seeing where people are going to the ER, and 27% of the cost of going to ER could probably be done either in primary care physician, urgent care, or even possibly Teladoc. So speaking of Teladoc,
I have a question. We're moving on from emergency room.
Okay.
So when you say the costs have gone up, is that all of the hospitals around the county, or is there one that's more of an offender?
I don't have that detail with me, but that's why I said, you're hearing it in the news, that it's, and they're not specifying certain hospitals, but most hospital systems are starting to do that. I couldn't speak to, and I don't want to put any of the hospitals here locally under the bus or anything like that, because I might be violating contracts, so I can't really speak to it. But that's why I'm telling you, in general, what we're seeing is most hospitals you're starting to see that, where, a claim that you probably saw 2 or 3 years ago was $1,300, and now it's $3,600. And you're just seeing that nationwide. It's not just specific to Mojave County, not specific to hospitals just in this area.
Any other questions?
Madam Chair, I have
Yes.
a question. On the primary care that's treatable in the ER rooms, is there any way to track, or do you track that to see if that's other than 8 to 5 during the day?
Well, that's an interesting question. So per your plan, we really can't, if they go to the emergency room and if it's deemed that it's not really emergent and could have gone somewhere else, we could actually, deny that claim and they can appeal it. But our claims analysts do review that information, and they'll go back to the ER and ask for more notes. It's never on the first claim, and we're not in there, but we'll have to get more information. And so we'll see if it was on the weekend, if it was a newborn, we take those kind of things into consideration when we pay those. So even though sometimes they are primary care appropriate, or maybe the primary diagnosis that's actually put on the claim, you had chest pains or something like that, and you go to find out later that it's just you had gas, or whatever the case may be, then it looks like it wasn't emergent. But to the lame person, it looks like, I feel like I should have gone to the emergency room. So a lot of that is taken consideration when we do pay those claims. But that's why we feel, if they call Teladoc first, at least the Teladoc person, the medical physician on the other end, you tell them what your symptoms are, they will then say, okay, I do think you should go to the emergency room, or they could tell you, this is what I think you do. So some of these people, if they would have called Teladoc, they probably could have avoided the ER. But I understand, because I've been in situations like that myself, where you maybe have had a really extreme migraine headache and thought, I don't think I can wait for a doctor, and I don't think Teladoc's going to be able to fix my brain right now. So you might go to the emergency room and then find out that, it's, here you go, here's some aspirin, and then it wasn't nothing major. So it's things like that we take in consideration. Does that answer your question?
Yes, thank you.
You're welcome.
Okay, anybody else? Okay.
Okay, so I'll move on to Teladoc then, as I brought that up before. So looking first at we broke it up because you have Teladoc, there's a $25 copay for your EPO, those members that are on the EPO plan, and then there's a $40 copay for those that are on the high deductible health plan. For those on the EPO plan, which is strange, usually we see with the lower copays and the easier access that these will have the higher utilization, but in your situation, it's actually flip-flopped where your high deductible health plan members are actually utilizing Teladoc more than your EPO people. Looking at, here's your information that we have here. It started off strong when they first introduced it in July of 2017. It was going up. We were really communicating, marketing it, making sure your members knew about it, but it's almost as if they forgot about it, and then it started going back down. But anybody who's used it, with their member surveys, they've loved it. You can see that they do prescriptions. So 73% of the visits that actually called in actually were able to get a prescription. And that's one reason why you want to use Teladoc, because you just don't want to go to a doctor's office, wait 2 or 3 hours, and then finally get that prescription that you were waiting for. You can actually call these people at 3 in the morning and then have where they call it in, and you can go pick up the prescription as soon as the pharmacy is open that morning. So there's great benefits for Teladoc, and like I said, we did bring some information so that we can help the benefits department communicate that again to their members. Looking at how much you've spent on this, even though it looks like it's low utilization, you're still getting, for every dollar you spend on the product for the EPO plan, you're still getting $3.82 back. So you're still seeing a return on your investment for this plan. Looking at the HDHP plan, again, higher utilization. This one, you're actually seeing $5.15 for every dollar you spend on this one. And so for overall, if you were to look at both plans put together, you're seeing about a $4 return on your investment. Again, everything is going good. The only thing I'd like to mention on the high deductible health plan, this is actually getting the higher participation. But looking at the member satisfaction, I went back to Teladoc because I don't like to see, if you're doing a survey, results of poor, so I want to get the information, like why did you have a poor experience? We have high utilization, so why was the poor experience? And I called up and I found out from Teladoc, they keep those records, and it was just because the member, they wanted a prescription and they wouldn't give the person a prescription, so they gave a bad mark. So that's really what that was about. Any questions on Teladoc?
I have a comment. I've used Teladoc, and it's fabulous. And it's a no-brainer, especially for those kinds of things. You know your body, you know what's wrong. Got the prescription, called it in, bing, bang, boom. So it is something I think is just to educate. Do you have things that you've done for some of your other, clients that works? We can incorporate it. Maybe, Mike, when we do our report to the board, we can have a Teladoc, because that, people watch the board meetings a little bit more, and because we really need to do it. It looks like it's saving us a ton, and people need to use it. It's easy.
Right.
I don't know if they're kind of afraid, or I don't know what it is, but once I used it once, I've used it twice now.
Right, and as soon as you register, I mean, that takes out most of the work
Right.
on it, you know, and then next thing you know, it's just a phone call. So we have done things in the past. Mostly it's communication. It depends on your employees and how they accept, you know, some people, they get an email and they see it from their employer, they trash it, you know, who knows? Or if you have regular meetings, areas where you can bring it up. So it all depends on the employer and how they communicate to their employees on what works best.
And remind me again that anybody, not even on the plan, like anyone in your household can use it? That's true too?
Yeah, I mean, if the employee's been paid and they know that that employee is a Mojave County employee, as long as they register their dependent, even that dependent isn't on the plan,
Right.
then they can still use it, yes.
Fantastic. Thank
So,
you.
you know, the only thing is that, for example, since they're paying copays, they will charge the copays, especially if you're on the high deductible health plan, that $40. But if the member is not on the plan, Meritain will get that information, and we don't have a person to apply it to, so it just doesn't be applied anywhere. But it still shows up the $40 in our claims system, so just
Okay.
denied.
Okay. Any other questions? You have a question?
Yes, Madam Chair. I have one more question. On the teledoc, can it be used for your routine annual prescriptions, you know, blood pressure, birth control pills,
So,
thyroid
yeah,
pills,
so
whatever?
your maintenance drugs. So, yeah, let's say that you're running low. And that's what's great about Teladoc is that when you register, you actually can enter your primary care physician's information. And so when you call them up and they go, okay, yeah, we can register or we can call in for a refill for you, they can do that, and then they notify your doctor so that they know that you got that refilled. So, yes, it does work for maintenance drugs as well. Yeah. All right, so moving on. That was the HDHP. Professional services, again, what's noticeable about this one is that your preventative services, you know, the increase in the preventative services is going in the right direction. So I'm just going to go straight right into preventative care. Just so you can see here, it's easier to look just right by the bar graphs, comparing 2017 to 2018. In the current states, you see that the percentages are higher. Again, lower membership on your plan, but you're getting higher utilization for your preventative services. And then going into the detail of 3 of your top screenings that are done, the number of eligible participants has increased in all 3 of these screening areas. So breast cancer screening, cervical cancer screening, and I'm not going to say that one, colorectal cancer screening. In every area, you actually saw an increase in participation compared to the prior year. So again, that's probably kudos to your wellness program. Any questions on these slides? Yep.
May I ask a question, please? For all of your slides and the financial information for the claims that are paid, the dollar values that you're representing, those are at the discounted prices, is that correct?
Yes, that is correct.
Okay, thank you.
That's the paid amount, correct. Good question. And so finally, I have a couple more things to wrap this up, but again, like I stated earlier, I don't want to just compare you to your prior year because we know how you're doing great. But how are you doing against Meritain's book of business, and how are you doing against the market in general, you know, against the BUCAs, the Aetna, Blue Cross, Cigna, and United Healthcare. Looking at your inpatient, the only place that you're actually seeing where you're, you know, a little bit higher, well, not a little bit, but a little bit higher than our book of business, 7% for the amount paid per admit, but you're 35% higher than nationwide industry. For your inpatient on how much you're paying for those hospital stays. But again, if you remember, you had those few outliers where it really shot up some of those numbers. So if we took those people out, you'd probably be right in line with everybody else. Your outpatient variance, same thing. Again, I spoke to this earlier with looking at your prior year. You had some of those outliers that shot it up. So for your outpatient paid per service, you know, looking at your previous year, mostly the emergency room and that multiple sclerosis patient, you saw a 45% increase in your patient paid per service or outpatient paid per service, which is 36% higher than the market and 25% higher than our book of business. But obviously, in the area where you're doing really well is the professional services. Everything is in the negative, how you compare it to yourself and how you compare it to our book of business. So, kudos on that area. And most of that is because most of your professional services are your preventative services, and those are your lower cost professional services. Other professional services that would fall in there are those professional doctors that are, they're at the hospital and they do some of their observation, or they go in and they talk to the member. So those get processed and paid as a professional service. But since you don't have as many hospital claims, then that's what drives those numbers down. And since most of them are preventative services, those are your lower cost professional services. Any questions on that before I finalize my presentation here? All right, so my final section here is just kind of a recommendations area that things that I saw as we spoke through this presentation. Again, about your average family size, with your dependents and your spouse being over 50% of your plan on your plan could cause adverse selection. But, and this is just the recommendation and not something I'm saying to do this year, but in the future, if you ever have where claims are getting outrageous and crazy, some of our plans, what they've done nowadays is done a spousal carve out. And what that is that basically if you have a spouse that's on this plan, but they're offered group coverage somewhere else, and the only reason why they're on your plan is because yours is so much, better, they'd rather be on yours, that just means, you might be bringing on a sick spouse and they want to use your plan instead. So a spousal carve out is basically saying, hey, if you're offered other insurance through a group, you work somewhere else, you have to take it. You will not be able to be on our plan. So again, I'm not suggesting it right now. I just wanted to bring it to your attention that that's something that other plans have done. And because your plan is running really well, you really don't have to do that right now. But again, looking at your population and how your membership is starting to see 50% or more of your members are dependent children or spouses. So,
Excuse
any
me,
questions on that?
is that something that is typical, where they don't allow people?
It's becoming more popular because of healthcare costs just going so, and right now, unemployment is down, so much that everybody, a lot of spouses are working, and a lot of employers are like, hey, look, I don't want to be paying for your spouse when they can, the cost can go to their employer instead of me. So that's, again, I'm just trying to give you like medical trend of what other, industries are doing out there.
Okay, so if both the spouse and your employee have that, where do the children go? Can you say you have to go with your spouse?
No, the children, that's different. So
Okay.
this would just be spouse. So you
Okay.
wouldn't say children have to go the other one to the other, because
Okay.
you have to legally, you will have to allow children to be
Okay.
on your plan.
It would seem to me that the government entity, the public money, that would be the norm. If that you would have to go to the other agency that you are employed with. So that's something I think we should talk about.
Well, and that's why I wanted to bring it to your attention. Yes.
Currently, I think, and I don't know how it works, but I think if you're on Medicare, Medicaid, or whatever, then the county pays first and Medicare pays second,
Group
correct?
insurance would pay first, yes.
So if we went to that kind of plan, could that be reversed, or is that something that the
Well,
feds decide?
the spousal carve-out is not for Medicare or Medicaid, it's for employers, because they want to try to push you that if you're getting group coverage, not government assistance, if you're getting group coverage from another employer, they want you to have that spouse get the insurance from there. So that's where it would come in play. Any other questions on that? Okay. My next one was, again, the ER utilization is down, but costs are still rising. Try to encourage the EPO members to use it more, because we saw the HDHP is trending higher than the EPO members. And so what I would like to consider if to bring that to the trust is, right now it's a $25 copay. It's only a $30 copay for them to go to their primary care physician. Even though it's fine, we want them to go to their primary care physician too, but I don't know if maybe their thought of, well, I can just go to a primary care doctor or urgent care, but the $25, you could, if you wanted to, lower it to $15 or $10 copay if you wanted to try to incentivize them that way as well, saying, look, we can make it where it's less cost for you to use Teladoc, by lowering the copay. So again, just another suggestion that you don't have to have it at 25. You can lower it down to as low as $5 if you want to. You can also do an unlimited one, but the fact that you're already doing a copay, going to doing no copay would be totally drastic, and the per employee per month that Teladoc is actually a little bit higher to charge for that one because it gives unlimited access, obviously, to a member. So I would just say just recommend lowering the copay if it was something that you wanted to do to try to incentivize the EPO members to use Teladoc a little bit more. Any questions on that? And then my final one, the utilization of the Aetna WRAP network, again, consistent with the prior year. It's still providing your members with additional access outside of Arizona. Obviously, you tested the waters first with your Colorado Strip members because they're the ones that lived up near Nevada and St. George, Utah. So you had where they were going. We had another network. It was the multi-plan network at the time. You weren't seeing as great as savings. It was only like 25 to 30% savings. So you introduced the Aetna WRAP to them. It was very popular, and then you introduced it to the whole population to allow your members to have access outside of Arizona, and you've seen that it's reaped great dividends because your members have enjoyed being able to have the access outside of Arizona. So I just recommend that you continue to keep the Aetna WRAP network. And that was it. So if you have any other questions, I will like to entertain those right now.
Any questions? I don't see any.
Okay, well, thank you for your time.
Thank you very much. Off.
Good morning, Madam Chair and members of the Trust. My name is Michelle Souls, and I'm the Strategic Relationship Executive at Blue Cross Blue Shield of Arizona. To my right, I have Jen Edmondson with me, and she works as part of our team from an operations area. Also a member of your team is Sherry Hurst. She is the Client Service Manager. She's at a client event today, so couldn't be here, but she works on your team as well. So today we are going to go over some changes at Blue Cross and Blue Shield. When we were most recently on a call with you a few months ago, we talked about some of the changes that we're seeing internally that are positively affecting groups externally. Some of those things are investments in technologies and faster to make changes. So we are hearing what clients and customers are saying and making changes internally to make services and systems easier for your members. We're also going to talk today about our discounts, our network performance. We're going to talk a little bit about Mayo, which we had talked about in a prior meeting, and Blue Card that's available to you coming in 2020, talk about our rate guarantees, and then some online resources that are available for you. So at this point, I'm going to turn the presentation over to Jen Edmondson, and she's going to talk to you about service and network updates.
Thank you and good morning. Can you hear me okay? Okay. I can't tell if my mic's on. We continue to have the largest network of providers in the state, and we're going to look at your member population's utilization of those in a minute. Resources and support, we do work with your TPA on a daily basis, and we make sure that the claims get to them within 48 hours for adjudication once we get them from your providers for pricing. I'm going to go to the next slide. And we're going to look a little bit at the discount savings that you're seeing in the network by using Blue Cross. So for the calendar year that we used, we're showing 59.4% as your overall discount on all claim types. That was a little bit off from what Meritain presented, and it looked like it was the time period that we were measuring. I think they had just over 60%. And then the next bullet, the average discount for our rural book of business is 50.9, so you can see that you are beating that by a very large margin, which is good to see. And we'll get a little bit more into the details on the next couple of slides. A benchmark that I think you've seen before, we like to show you that on that 59.4% of savings, every 1% of that is really worth $210,000 to your total medical expense. So we want to make sure that you understand with your total overall medical spend how valuable that 59.4 is. The utilization looks really, really good this year, and it was very consistent with last year as well. We're seeing members using 100% of contracted facilities, 99% of professionals, and that would also include outpatient. So very good in-network utilization there, no problems. The next slide is going to break that down just a little bit for you into inpatient, outpatient, and then your professionals. So we're seeing very consistent results year over year. The outpatient actually improved a little bit, and that's where we would be seeing those ER charges. So I wanted to point out we're not typically seeing increased reimbursement for ER from a network perspective. I just wanted to mention that because it was an issue in the prior presentation. We actually saw a 2% improvement in your outpatient discounts this year over last year, so that was very, very good. Any questions on this slide before I move on? Okay. This is a really hard slide to read, but I believe the detail is provided in the addendum to the presentation. We like to show you your top high dollar claims that were billed to the plan and what types of discounts that you're seeing on the high dollar. Some of the things that are going to jump out at you are the red, where we have a negative discount, or there's one in the top 25 that has no discount, so I just wanted to comment on those briefly. We have a contract with Flagstaff Medical, and that's where you're going to see those reverse savings. They do not, at this point, take lesser of logic, we call it. So if they bill a certain dollar amount and we assign the DRG based on the medical records that we're seeing, most hospitals in the state agree to take the lesser of what they billed or what we will reimburse on a DRG basis. Flagstaff Medical has not agreed to that in their contract, but it's been an ongoing effort. The CFO I hear from Flagstaff just left in the middle of those discussions, so we're going to have to restart those discussions with the new CFO. That lesser of logic is what protects you from paying more, obviously, than what a facility has billed, because we don't base our reimbursement on what they bill. We base it on the diagnosis and the taxonomy and a lot of other pricing factors. There's a bit of a science to it. The one that shows 0 is an example of a facility like Banner or Kingman Regional that does take lesser of. So our DRG assignment would have been higher than what they billed, but they agree to take lesser of. So we are able to protect the plan against that. Flagstaff Medical is the only facility I'm aware of in the state that does not agree to lesser of logic at this point. Any questions on that data? Yes.
Have a question. So for the patient that's using that particular facility, do they have any idea that that's going to occur? I mean, obviously it's going to be more out-of-pocket expense for them.
They're not allowed to balance bill in that case any more than they would for coinsurance, or, and I shouldn't say balance bill, but they're not allowed to charge the member any more on a deductible or coinsurance. It's really the money that comes out of your plan fund at that point. So
wow.
the member is not going to be further harmed by this.
Thank you.
On that, I just want to clarify that. So let's say I go there, and I'm on the high deductible, so I'm paying 100%. And, you know, it's 2,500. And so you're saying that I will only pay what you guys come up with, or?
In the situation where we don't have the lesser of logic for Flagstaff Medical, I don't believe that it impacts the member because the plan is going to pay the higher amount. But I understand what you're saying about the high deductible. I'm not very familiar with your health plan,
Okay.
your plan benefits. But I suppose it could be a case where the member would have to pay if they were on a high deductible more than.
Why would
for a
that
hospital.
facility be in the network if they're not, you know, playing by the rules that the plan has?
It's a very high utilized
Is
facility
it?
for a lot of our members, and we've really worked hard to keep them in the network for that reason. That's considered a rural area as well in the state. And the negotiations have been ongoing for years about trying to get them more in line. And this is sort of the real last issue that we have is this lesser of logic. So I did talk to the contracting director last night about this to make sure we were still on track with them. And she said yes, but again, because the CFO had departed in the middle of the discussions, they're kind of back to square one with that issue.
I like that lesser of logic. I think we can use that in a whole bunch of government things.
Yes. Yes.
Yeah, Madam Chair, when speaking about Flagstaff Medical Center, you can key the Darth Vader music. But the simple answer, Jen was being very delicate. It's not one of my attributes. I would say that the simple reason is because they can. They have no competition. They control air ambulance. They control ground ambulance. They control management contracts with other hospitals. They have alliance agreements with other hospitals to send them specific classes of business. So, I mean, back in the days of the early 1800s when trust busting was going on, if you remember your history with Standard Oil, Flagstaff Medical Center would have been in that league. And unfortunately, today we don't have the type of flexibility that we had with them. So that's my delicate but simple response, because they can.
Thank you for that honest answer. Thank you.
Thank you, Aaron.
Anyone have any other questions? Okay, thank you.
All right, I think we're going to turn it back over to Michelle to talk a little bit about the blue card potential.
Thank you, Jen. So we talked a little bit earlier about the overall network, and Blue Cross Blue Shield has the largest network delivering the deepest overall discounts, not only in the state of Arizona, but the power of the blues nationwide. So what that means to you and your members is that you will see 96% of hospitals participate as in-network providers, and 95% of all providers and physicians are in our network. That equates to about 1.9 million professional providers that are part of the Blue Cross and Blue Shield network. We service every zip code within the U.S. and the U.S. territories. And earlier I alluded to, we have some changes that are happening internally that will potentially positively impact your members. So starting in 2020, we have the availability to bring a Blue Card to you. What Blue Card does is allows you to use Blues networks in other states. So your members will have one ID card, but they will be able to use all Blues networks. So they can use it in Nevada, they can use it in California, and it's seamless to them. And it allows you to not have to have a wrap network if you so desire. So that is available coming in 2020 and with the renewal period in 2020 for you. So for you, that would mean 7/1 of 2020, and that's with approved TPAs. So if that's something that you're interested in looking at, we can work with the team at Aaron Collins, and we can look at your out-of-network spend and work with your actuaries behind the scenes to help you get a better idea of how that would impact you financially.
I have a question. So how is that different? What would be the difference, the benefit for the employee from what we have now? Because right now that you can go to another state. So what would this do that would be different?
So right now, employees can go to another state, but when Rick was talking, he was talking that you use the Aetna RAP network. So you would switch from, or potentially employees would switch from using an Aetna RAP network to using a Blues network. And so everything in network, and if you're thinking about it today, what is currently today out of network would become in network because it would be seamless across state lines.
So this is something that this board would have to decide to change from Aetna to, okay. Thank you.
And again, looking at your utilization, I think Rick mentioned that there was about 1,100 claims that were out of the state of Arizona. So we could, again, do an analysis of that and look at where that is, what those dollars are, and work behind the scenes with the actuarial. So you have some comparative data. But I wanted you to be aware of that from the timing standpoint of how far you make decisions and what you're looking at. And so we can provide that information for you. And again, it gives you the possibility of having lower access fees and lower exposure from a financial standpoint if you desire to make that change. Is everybody good?
I just have a question about the charge to the county for that. or to
So
the
as we talk
individual.
about fees, I'll get a little bit, I'll give you a highlight of that when we get there. Is that okay? Okay. Mhm. So a few months ago, we had talked to you about Mayo, and we started a partnership with Mayo in May of 2017. Currently, Mayo is excluded from your network, but from a book of business, wanted to reiterate that Blue Cross of Arizona has Mayo as a in-network provider. Despite the commercials that you see for Mayo on TV, and sometimes you even see them on billboards or on the radio, they still have a very stringent intake process, and they still are looking for the rare condition and the, if you will, not normal condition. So while we have this extension and to exclude Mayo on an ongoing basis for the group, wanted to share some of the insights with you that what we're seeing from a utilization standpoint. So across our book of business since implementing implementing Mayo, we're seeing about 6 to 7% increase in total allowed expenses being paid to Mayo. Now today, or prior to that time, those expenses were going to other networks. So it's a shift, if you will, of moving from one network provider to another. We have heard members say that it is, and they've reinforced, it says, well, Mayo's a network, but I can't get in. They won't let me, they won't let me be seen. So from a financial standpoint, we wanted you to be aware of that. At this point, the exclusion to keep Mayo out of network for this group goes through 6/30 of 19, and later this calendar year, I'll have an idea.
Joined the conference.
I'll have an idea how much further we can extend that exclusion if you desire, or if you want to bring it into network, we can have that conversation as well.
Any questions? Just for maybe people who are watching and don't know, with our new contract, we were told we had to go to Mayo last time, but we got an exclusion for the year that comes up June 30th, 19, and it all has to do with the cost. Okay.
Correct. Thank you. So next, moving on, giving you an overview of the renewal rates, and we were able to secure a 3-year rate guarantee. And as you'll see on the slide, I call it non-Blue Card, because we were talking earlier about the possibility of adding Blue Card. I want to make sure that you understand that these are the administrative rates for the non-Blue Card piece. If Blue Card is an option and something that the trust wants to consider, at this point in time, we're only, because it's new to us from an implementation standpoint, we're only doing 1-year agreements. That may change as time goes on because we're just starting to implement it for 2020, and I can get those rates for you. I believe what you will see is in addition to your administrative fee, you will see an access fee to access Blue Card, and then you will see a % of savings. And we can provide that to the team at Aaron Collins and share that with you. And if you'd like, in a future meeting, talk to you about that as I don't have rates that far into 7/1 of 2020 yet. Okay, so I'm going to turn it back over to Jen just to give you an overview of some of the online resources and tools that you have available to your members. I think with all the vendors that you see, sometimes we forget some of the resources that are available so your members can utilize the network and resources available to them.
Thank you. I'd just like to reiterate when we're visiting with the groups, we do have a specific landing page and provider directory for your group. It is the statewide PPO network, and it can be accessed at the URL that's in the slide. That URL is provided to your TPA so that they can post it on the member portal. You can use it in any of your open enrollment collateral. We really encourage people to use this URL as opposed to going to azblue.com. There are many networks out there, and we want to make sure that they're accessing the right one. I have not seen this as a problem for your group at all, but something to keep in mind as you're crafting your communication material. The last couple of slides just show you what it looks like when you get there, what you can expect to see. And we had rolled out this new provider directory probably 2 to 3 years ago, and it has many more search functions than the old one did, so you can really hone in on an area, a specialty, a name, print a map, things like that. So if you ever need a demo or your members need a demo, we can certainly provide that. Any questions?
Anyone have any questions? On that page, does anyone get access to see how many people utilize it from our plan?
We wouldn't know by plan. I would know by my book of business, which includes 90 groups.
Okay.
We could look at the TPA. That wouldn't tell you your plan either, but we could see how many people are going in through Meritain.
Right. Yeah, it seems like a pretty good resource. I didn't even know about it, so
Okay.
maybe we just need to do a little better job in getting that information out. Thank you. So we're done with number 4? Erin? Okay. Item 5, prescription drug utilization.
Okay, Madam Chair, in this case, I'm going to substitute in for Magellan. They were in the process of a account manager transition. They have been advised that there's a recommendation that they be replaced by Navitas, so we had a conversation about, in light of that recommendation, knowing that the vote had not been made, do you want to present, because they would have had to fly somebody either from Ohio or Idaho to do the presentations. We just gave them the option, and they said, go ahead and present. So basically, I'm going to present their report. We spent some time with them yesterday on the phone, picking out the key indicators in here, so I'm going to walk through those with you. I'll be happy to answer any questions. I'm also going to point out some of the issues that we saw in here that will be of interest in the transition, assuming the board votes that way tomorrow. Okay? So if I could, what I'd do is direct your attention to slide number 4, which at the top is the statistics slide. There's some pretty good information in here. At the upper right, under the key metrics, a couple of them, there's some letters in there I'd like to explain because we always get caught up in the nomenclature and people get lost by it. But you'll see one figure up there. It's total scripts issued were 15,059. Next to that is a 3 letters GSR, and what that means is generic substitution rate. So 98.46. So in essence, to the degree that there were generics available, 98+% of them were actually transitioned from the brand to the generic, big savings on every one of those. And then the other one is the generic dispense rate, and it was at 87%. So 87% of the drugs that were dispensed through the plan were generics. And what you'll see with that is that that would represent typically less than 10% of the cost or 15% of the cost on that high percentage, because really what's expensive is the branded drugs, and then in particular the specialty drugs, the infusions and the really highly meds. Overall in the plan, 5.75, so roughly 6 prescriptions, unique prescriptions, on average per plan participant per year. So in the case of a maintenance drug, birth control or Synthroid or high blood pressure medication, if they could have 3, 4, 12 scripts, but it would only count once because it's per drug dispensed per year. So that's actually fairly low. By comparison, we see this figure anywhere from 8 to 9 or 10 across. So it's actually a fairly low number for a group of any size, particularly with this one. Down into the cost data, you'll see it's got total, specialty, and then without specialty. The key metrics in there is really what percentage of the costs are being borne by the plan versus members. The plan is in blue, member is in red. Overall, the plan is bearing about 84% of the costs. And really what drives that is the specialty meds again. You'll see that as we get into them because, again, on average, a normal specialty med would be somewhere in the range of $1,200 to $1,800 per month. We have cases, including on this plan, for particularly complex disease states where we'll hit $30,000 a month for one script. So it's, given the size of the plan, it doesn't take many of those to really skew the numbers. So overall, I would tell you these figures are in line generally with the book of business. There's a very good example down below on the top 5 drugs categories. It's the second one down. I can't read it, I apologize. It's the middle-age blindness thing, but Sindentico or something? Sindecco. It's a miscellaneous respiratory. We had a single prescription of that issued at in excess of $70,000. That was one script, okay? And everybody do the same thing, Berlin, is, you bang your head and go, my gosh. But for this particular disease state, the option is literally, without exaggeration, is death. And so as nightmarish as that is from a financing perspective, the standard answer in our office is no one volunteers for this, and this is when you're really glad that you have health insurance. Okay, and this happens to be a drug that treats cystic fibrosis, which is a medical condition where the lungs build up a very, very heavy mucus. Traditionally, even as recently as 25 years ago, people would not live, maybe 15 years at most, and now we're seeing somewhat more normal lifespans, 40s, 50s, 60s, because these drugs are available. I'm not saying that price is fair, I have no idea, but it does make a difference in life expectancy, quality of life, that type of thing. So those are kind of the key metrics on that page. If you go to the next one, page 5, I can tell you there's an error in here. And where that error is between 2017 and 2018 on the number of members. And you'll see it jumped from 2059 to 2618. And what this is belly buttons on the plan. This is every man, woman, and child. And it goes back to one of Rick's numbers. And he said that basically you have 2.1 members for everybody carrying dependent coverage. And we checked. We asked them to run a report on their system last night. The correct figure is about 2,058. There's some kind of a glitch in the reporting system at Magellan, and we're seeing that with other accounts as well. So the membership, the population is actually slight decline year over year, and it'll vary. That's not really a trend, but it'll vary. It just depends on what your turnover rate is and how many dependents people have that leave versus how many who have dependents as they come on. So the group's actually remarkably stable. Costs, again, there's nothing on this page that really is shocking. I would ignore at the very bottom of that page in the lower right, I would ignore that per member per month charge of $46.22 because I think it's distorted by the incorrect reporting above. Okay, the picture that is here is again remarkably stable. The next page on page 6 shows the rebates that have been issued per quarter. Running a little under 70,000. We are aware that the next month's came out, it's about 60,000. So we're averaging on the rebates somewhere in the vicinity of $300,000 a year. What we don't know, because this is not what's called a transparent contract, which we're recommending moving to, We know 300 came back. We don't know how much was not returned to the county because they're not contractually obligated to do so. Okay? Moving on into page 8. And this is the top. These are those specialty drugs again. And you can just see across the page. I mean, these are just incredibly expensive drugs. However, when you look at them, again, the number one is the Symdeco, the one for CF. But then when you look down through the majority of them after that, a lot of them are related to cancer. And when we look at the large cases for the trust, what we see historically is a fairly substantial number of cancers, and we're seeing that this year. The good news on the cancers and on the large cases in general, and Rick's talked about it to a lesser extent, Blues did, is we're seeing a remarkably good year. And where it's occurring is in the large cases. I looked up the large cases, or Bob and I did yesterday afternoon. They are about a third of where they were last year. Some of the large cases who are on the plan, just due to life changes, have come off the plan. And those two of them in particular represented about $600,000 in claims in the previous year. So whatever happened, they moved, they went somewhere. It was good things, not the dark outcome, but they moved and they went off the plan. And that and just some pretty good fortune in terms of how the claims have played out this year have worked out. But the takeaway in here really is that this county's plan, in our experience all across Arizona, has a disproportionately large number of cancer cases every year, very consistently. Okay, the one area that we've targeted on the wellness program, and that we actually showed up in Rick's numbers, is we're continuing to push on breast cancer, because when we first looked at the county in terms of wellness and early detection, that was the bell ringer. The one that is surprising because we don't see the incidence of that across our book that we see here. And importantly, the county has a comparatively low percentage of women who do breast screening. It's much lower. It has historically been much lower, and frankly, we're not sure why that's the case. We've seen that as the higher that percentage of women over the age of 40 getting an annual exam, the higher you can get that number. You get it in the 70s, the 80% range. The dollars spent on breast cancers decline fairly dramatically, fairly quickly. And so far, we have not turned that corner yet on Mojave, but that's a continuous target area for us. So anyways, again, looking in here, what you're seeing really is specialty drugs, and you see the concentration in the cancer drugs in particular. Moving on to drugs by cost on page 9. In here, again, we see the cancer. This is total drugs by cost, but we also see the anti-diabetic medications. That is not necessarily bad. I'll give you the qualification on that. Livongo is going to talk here, and one of the issues with diabetes is that you want people testing if they've got the disease, you want them medicating, okay? So the fact that they are taking the medications is good because it tends to slow or arrest some of the degenerative conditions that go with diabetes, the loss of extremity, the kidney failure, the ocular damage, all coronary issues. They all come in a cluster. So if they're medicating, they tend to slow that progression. Okay, so it's really key. Where it'll become important if the vote is to switch tomorrow is how the formulary is constructed by the prescription benefit management company to direct people to lower cost, but trying to get the correct terminology here, but medically correct medications to control it. So are they being steered towards the most effective, lowest cost combination? And I think that's where we'll see an opportunity going forward on the prescription drug side. So good news is that they are using their medications. We're seeing an increase in the actual utilization. The question mark is whether or not that's the most cost-effective medication, and we'll be working with that one in subsequent years. And then on page 10, the only one I would call out is the 7th item on there. This one is by therapeutic class. The 7th one is dermatologicals, and I called them out on this one just to double check and make sure that this was not basically acne medications. It's not. It's for conditions like psoriasis, okay, so they're fairly common, but again, expensive. And again, at the top, the good news, you see the anti-diabetics, and then everything else kind of running through is pretty much standard stuff, the cancers and whatnot. If you go to the next page, on page 11, you'll see the adherence issues. And what this is they take a look at high-cost areas by therapeutic class for adherence. And basically, adherence is, have they missed any prescriptions? So if you look, they want on HIV in particular, they want a 90%. They're below that. So we do have people that are treating for that disease state that have actually missed scripts. I would not raise a red flag on this hugely because the number of people with that condition is very low. So a single script by one person can distort the number, okay? The diabetic adherence is a concern, if 70% again, particularly with type 1 diabetics, who are insulin dependent, obviously not something you want to miss because if they go out of control, they wind up with very serious medical conditions, inpatients, emergency rooms, that type of thing. And then the hyperlipidemia or the dyslipidemia, this is for basically the coronary issues. And Mojave, again, this is a huge area. Jamie will talk about this later, but this is a huge area of cost drivers for the county also, is cardiac claims, just in broad strokes. So we'll be passing this information along if the vote occurs tomorrow to switch to Navitas, just to then have them drill through. We've already passed them a file, a de-identified file, so they can start analyzing the claims data to look for opportunities in there beyond the pricing, but for program and structure. Opioid issue, I call this one out because it goes into some of our recommendations for benefit design changes. There is a much larger than expected, I should say much, probably I'm going to just back of the envelope say a 20 to 25% higher expense on opioids for the county than we would typically expect to see. However, that's not unusual, and we're making some recommendations on a structure to help with people who may be addicted, and I say addicted meaning in a non-medically necessary, because these drugs are particularly potent, but there's also a time where the addiction simply doesn't matter, and you got a high incidence of cancer on there. Frankly, who cares if they're addicted to opioids and they're at end stage of cancer? These meds are built for breakthrough cancer pains. The combination that worries us, or that have concerned us, there's a classic combination that tends to be fatal, and it's opioids mixed with benzodiazepines. And the benzodiazepines are things like Valium. It's that class of medicine. But what they haven't taken together is they're both respiratory suppressants. So when you get people who mix them, they're obviously dulled to begin with, whether it's through addiction issues or just pain medicine mismanagement. The combination tends to kill them because they're dulled. They can't remember necessarily if they've taken the correct dosing, or if they've taken a dose, they take another one, take a nap, never wake up. So what we're going to be looking at in here, and our recommendations later are just some adjustments to do a thing called mental health parity, which I'll get into, but then adding a case management component strictly for mental health and substance abuse. So to the degree we have people who are addicted, who are not in a condition of end-stage cancer or similar conditions, that they will be able to go to a specially trained case manager who will help them deal with that addiction using the appropriate network. So it's a fairly complex one, but we've done it with some high degree of success with our other counties around the state, and we're using that exact same model and an existing vendor to the county to construct it. I saw, Madam Chair, a question?
Yeah, so in that program, it's voluntary, not mandatory, to get their medication.
100% voluntary.
Okay, thanks.
Okay. And I would point out, Madam Chair, same model we're doing now with medical case management, traditional medical case management, 100% voluntary if somebody wants to do, and 100% private. So funded through the plan, totally voluntary on their part, and 100% privacy managed.
Very good. Any questions about that?
Okay. And that's pretty much it. The last page on is, there's a page that's got kind of a circle of that one on there. And this is the same thing. We would see something similar if the decision's made to go to Navitas tomorrow, but it's basically for specialty drugs. They're expensive drugs, but it's very critical how they're administered if they're going to be effective. And they're dealing with things like hepatitis C, just a whole range of serious medical issues. So both of the organizations, and this is common throughout the industry, have support mechanisms for somebody on the medication where they can call, speak with a pharmacist or a technician who can make sure they're administering it correctly so that the medicine has a higher opportunity to be effective. And we would plan on duplicating that as well. So to the degree I can answer any questions, Madam Chair, I'd be happy to do so.
I have a question. So when they were looking at the cost from year to year with the medication, there was a big hike between 2015, 2016. And I think I remember from that meeting that was when that hepatitis C drug was developed, and it's a great drug because it cures hepatitis C, but it has that big expense, but it saved people's lives. So, you know, it's kind of like you're done. So do you see, are those types of drugs usage going down in our county, or is it we just cycle people who had hepatitis C that needs to use that drug?
Well, the specific, Madam Chair, the specific disease states vary, because the one you're talking about, the Hep C drugs are about $90,000 a course of the medications to do, if they run the full course. Some are actually cleaned up, if you will, of the disease state after about 60 days, so they'll go about 2/3 of the way through. But that entire class of medications has gone from being less than 5% of the spend to about 30%, and more of the industry is shifting that way because of the opportunity for money to be made. They're difficult to make generic because of the nature of their manufacturing processes and how specific they are. They're moving more into the genetic level on the treatments. So our expectation is that you will continue to see those costs rise over the years. So it's not necessarily disease state so much as it is the way the industry is moving.
Okay, thank you.
Sorry, Madam Chair, members, at this point, what we're going to do is we're going to switch, this is where we're going to switch the order
Right.
and have the Livongo folks come up, and what they're going to do is walk through. You'll remember that last year we implemented a diabetes disease state management program. It was specifically targeted diabetes. We've got about 6 months of data. Rather than steal their thunder, it's good news, but I'll let them walk through it, and with your permission, Madam Chair, I'm going to step out just for a second, then I'll come back in, and he'll do the presentation. In the meantime, we're also going to have a Livongo rep is going to call in on the overhead to walk through some of that data as well.
Okay, so this is,
Yeah, I think she's on.
this is number 8 now, so for those keeping track. And we'll go back to 6 in a minute.
And hi, everybody. This is Krista Vandro with Livongo, so I am on the line here.
Hello.
Hi.
Before we get started, does anybody need to take a little break for any reason? Or can we power on? Okay.
And Madam Chair and Trustees, hi, I'm Noah Slobotsky.
Hello.
With Livongo. I'm Regional Sales Director out of Kansas City. And so Krista will be taking the lead to walk you through your results, and then I'll touch base at the end to talk about our new hypertension solution, to parlay off of what Aaron was saying about your cardiac issues. You know, I think it's worth touching on that and maybe of interest to you down the road.
Okay.
So, Krista, we'll let you take it from here.
Know when we're ready to get started.
We're ready to get started. And can you introduce yourself again on the phone?
Yeah, sure. So, hi, everybody. My name is Krista Vandreb, and I am an account manager for Mojave County here at Livongo. And as Noah mentioned, you've got Noah on site with you all, and he's our regional sales director. And I wanted to start off by thanking you for this opportunity to present at the meeting. We are really excited to share the results from this program. And the goal for today is to really provide you with a snapshot of how the Livongo program is doing, and that's in terms of enrollment and engagement and clinical outcomes. And then, as Noah mentioned, to provide you with an update on our latest offering, which is hypertension management.
Very good.
So the data for this business review today comes from program launch, which was back in June, through the end of January. And just given the time, I'm going to be moving pretty quickly through these slides, but please do stop me if you have any questions. Okay? Okay. And can you all still hear me okay?
We can hear you fine.
Okay, great. So here is our agenda for today. So I'm going to start out with a summary of our key findings from the program over these past several months. And then what I'll do is take a closer look at the data and metrics behind these findings. And these are grouped into the 3 ways in which we measure the success of the program. So there's member satisfaction, which includes the satisfaction survey results and a net promoter score. There's member engagement, so that's a look at enrollment and then activation, which I'll define once we get there. And then thirdly, clinical outcomes. So we'll look at the extent to which the program is helping to reduce members' HbA1c levels, as well as to what extent is it helping members keep their blood glucose in the safe range. And then we'll wrap up with Noah speaking to the hypertension management program. Okay, so let's start off with the executive summary. So, at the highest level, the Livongo program has delivered very positive early results for Mojave County. This is really one of the strongest kind of examples I've seen across the clients I work with. And we can see, based on the member satisfaction survey data, that Mojave County's members are truly getting value out of the program, and they're also feeling more empowered to manage their condition, which we know ultimately leads to better health outcomes. We've also seen really strong results on the clinical side. So we have seen that the HbA1c levels have been reduced by 0.9 points in the first 6 months. And then with regard to spending time out of range in terms of the blood glucose values, we know that members are 46% less likely to have an out-of-range low blood glucose reading. And that may ultimately reduce visits to urgent care and to the emergency room. So what we'll do next is take a closer look at the data behind these trends. And I wanted to provide you with some context on how we assess member satisfaction. And we do so in 3 ways. So the first is by assessing a net promoter score. And you may already be familiar with this, but the gist is that it is an index that goes from negative 100 to positive 100. Anything above 0 is considered to be a good score. And it's really a measure of customer satisfaction and loyalty. We are proud as a program for our book of business to have a net promoter score of plus 66, which is close to a market leader, which I'm sure everybody's familiar with, which is Netflix. And they have a net promoter score of positive 68. And then second, for member satisfaction surveys, for a given member, we send out surveys at regular intervals. So they'll receive one at 1 month, 6 months, 1 year, and every 6 months after that. And then we aggregate those survey results for that given survey, and we present the results back to you. So you'll see results in this business review for the 6-month survey. And then the third way in which we assess member satisfaction is through a clinically validated survey instrument called the Diabetes Empowerment and Distress Scale. We administer these questions at regular intervals, just like the member satisfaction survey, and they get at the degree to which members feel more confident about managing their diabetes, as well as the extent to which they may feel more stressed. Because we know that if somebody hasn't been actively managing their condition, once they get back into it, sometimes their stress levels initially go up for a bit. But ultimately, we want these scores to decline. And I'll pause there to see if you have any questions.
Does anybody have any questions? No questions here, Krista.
Okay. So here are Mojave County's results for the NPS score and the member satisfaction survey results. And you can see that these are really strong scores. So for the Net Promoter Score, it's a positive 65, which is just 1 point shy of Netflix. So I think this is fantastic. And then for the member satisfaction survey, you can see that Mojave County is represented by the green bars. Our book of business is represented by the blue bars. And your scores are exceeding the book of business across every measure. So what I really like to see is that, in order for people to be counted in this, they have to strongly agree with each statement. And it's great to see that people strongly agree, 82%, that they want to keep using the health program, and also that they're pleased with the benefits team for offering it. So these are great marks. And the second thing we'll take a look at is that clinically validated survey instrument, so it's the Diabetes Empowerment and Distress Scale. So I'm going to orient you to what's going on with this slide. The Diabetes Empowerment Scale, it assesses how empowered or confident do members feel to manage their diabetes and improve their blood glucose control. So this scale goes from 1 to 5, with 5 being the most empowered. And the scores for Mojave County pre-program were actually pretty high overall, which is good. And generally, if scores start higher off, we see that the net change is smaller. But I'm pleased to say that on several of these measures, we've seen a change of 0.4, 0.75 for another one. So it's fantastic. And then likewise for the distress scale, the scale here is kind of the flip. It goes from 1 to 6, with 6 being the least distressed. So we want these scores to be as close to 1 as possible. And for Mojave County here, we see huge declines. I rarely see declines this high, where it's almost coming up to a full point decline. So, again, all this data is indicating that things are moving in the right direction. And one thing I'll note, if you see on the slide that these results here come from the 1-month survey, the reason why is that we need to, when we present out results, we need to know that our results are statistically significant. So ultimately, we'll be able to report out for the 6-month survey, the 1 year, et cetera. We just need to have enough people responding to the survey so that we can make sure that the results are valid. Okay, and I'm going to move on to member engagement now. So here is a look at our enrollment and activation dashboard. So we have Mojave County in green on the right, and then our benchmark for self-funded employers in blue, Mojave County's on the left, and then the benchmark is in blue on the right. And we've got enrollment on the top section, so that is when somebody successfully registers for the program, and then activation on the bottom. And activation is when somebody enrolls in the program and then they successfully use that device, the blood glucose meter, for the first time. So we can see here that enrollment for Mojave County is at 34%. And really our gold standard for enrollment for this program, our target is 40%. And this is great to see that, it's still relatively early in the program, but we are well on our way to hitting that benchmark. And then for activation, you can see that Mojave County is about 8 percentage points higher than our book of business. And this is great. So what that indicates to me is that people who register for the program, and sometimes there is a little bit of a delay before they actually use that meter, but what this indicates to me is that people who enroll are very motivated to get started and get using. I will say that once somebody does register for the program, they get put onto sort of this journey where they receive communications that encourage them to actually activate and use the meter. So that's kind of what happens at that stage. And moving on to the next slide. So this slide is our cohorts checks dashboard. And what it's showing here is the average number of blood glucose checks per day on the days where people are checking at least once. What's important to know here is that as a program, our goal is to drive appropriate use. And what that means is that how often somebody should check their blood glucose, it varies based on several factors. It varies based on the specific diagnosis, so whether it's type 1 or type 2 diabetes, how long the person has been diabetic and how well they've been controlling their condition, whether they're on insulin or any other medications, and then lastly, most importantly, is input from their physicians. And what's unique about our program is that members have the ability to share their blood glucose results, their historical tracking and data with their physicians to help kind of manage and get from their physicians onto the right number of checks per day, and then ultimately on the right medications, or if medications need to be adjusted. And then, so for Mojave County, we see that about 92% of the enrolled population has type 2 diabetes. And that's pretty much on par with what we see across our book of business. In the table below, you see that the Livongo clinicians have set a goal for the number of checks per day for people with type 1 and type 2. But again, keep in mind that what we're after here is appropriate use. So we can see that the people on type 1 are doing really good relative to the Livongo goal. They're about at 3 checks per day. I rarely see numbers above about 2.5, 2.6, so that's really positive. And then for type 2, we have them, Mojave County, at 1.83 checks per day. The goal is 2. And again, this is good because the population is slightly above our book of business. And then the recommended checks per day for type 2 members not on insulin is between 0 and 2. And so it's a range. So it looks like Mojave County is just a little bit above our book of business, so we're doing well on that front. Any questions?
Does anybody have any questions for Krista? I have just a little comment on when you're talking about the usage of it. So just so we can recap, this was a program that was put in a year ago. Is that correct? Right?
Yeah, we're at about,
And it's free to the end user. And what kind of efforts were made to reach out to that population? Because, there's 34%, but there's still 66% who are not using it. Has there been reasons, or what's sort of the word on the street on that?
In terms of reaching out? So for Mojave County, we, just by the way the contract is structured, so we do not do targeted marketing. But I have been in communication with our marketing team, and we can send out or produce, and I'll get to this a little bit later, but we can, they've been willing to produce additional materials if you'd like to do additional program promotion.
I think Erin wants to weigh in on this.
Yeah, Madam Chair, we did some work with this with Magellan. And what we did is we did a mailer to anybody that had an active diabetes medication script. So we sent them out to that. So the incentive basically in this case was simply the actual participation in the program at no expense to them. As has been mentioned, the participation here is actually higher than we expected because the only incentive was the meter. We have run a program, different approach with some of the counties around the state that included a copay waiver if they signed up. We've got that one went to the mid-60s on participation, so the 63, 68% kind of in that range. These numbers are good. The concern I would have with what we've got here is when you look, when they were, and I apologize on the Livongo person on the phone, I just drew a blank, but the people who were in there actually felt that they were doing pretty good managing the disease state. There was still some improvement. So I think what we may have an overrepresentation in the population of people who are already doing a good job, which is good. You want to encourage them to continue to maintain well. But I'd like to see us get into that mid-60s because the target is that other ones who are not doing so well, because those are the ones I think who are probably more likely to have complications. So in our thing, and we'll get into it later with Jamie when she looks at this briefly, our target is somewhere to get into north of the 60% range for participation in this. I think if we're going to have a real long-term impact, we need to really be moving in that
Right.
range.
Well, now that you have this kind of feedback, you can, do another marketing to them and, say that how well everyone likes it, because no one really wants to try anything new.
No, exactly. And but frankly, this is a tough disease state. Like I said, we were thinking we might get 20%, so to get where we got was actually pretty good.
Yeah.
But again, you never get complacent. The reality is you want to continually target it because there's always turnover and there's always new diagnoses. So we have actually a marketing, and Jamie just promoted actually into a consulting role. She was one of the ones who did these marketing campaigns, but we're bringing somebody on to do periodic marketing campaigns working with the PBM and 100% targeted to people that have those diabetes-related prescriptions. That should continue to move the needle.
It was a great program when we voted it in, so I'm really glad to hear that it's been this successful. Do you have a question?
Yes. Thank you, Erin. Those are great points.
We have another question, Krista.
Sure.
Is there any new mailer for a new employee or a new person that now has the need for, any of these products that you can identify?
Madam Chair Verlin, I honestly don't
That was-
recall when we did our last one, and I'd have to, oh, do you know? Jamie knows, hang on.
Turn it on. Yeah, so we're still sending monthly mailers to anyone who newly fills a diabetic prescription. So the first time we just did through March through December or whenever. So that's, we did that big bulk mailers. And then each month we go through the PBM and look at any new members and then new diabetes medications filled and then send those out.
Thank you. Answered your question. Any other questions? Okay.
Okay. All right. I'm going to skip over this slide, just in the essence of time here, and move on to clinical outcomes. So, really the purpose of this program from a clinical standpoint is to help get people's HbA1c levels into a range that is below 7%. And for those of you who are not familiar with HbA1c, that is a measure of how well somebody has been basically managing their blood glucose level over the prior 3 months. And we know that from studies that we've done with many of our larger clients, that each percentage point reduction in A1C leads to reduced health risks for the member and then potential cost savings for you all. So to take a look at Mojave County's results here, this graph is a representation of the HbA1c levels. So when somebody registers for the program, they self-report their HbA1c. And, we don't have data from before Livongo, so we ask members to report that. What we do for these subsequent intervals is that based on the blood glucose readings that are collected via people's meters, we then estimate their HbA1c levels. And what's great here is that, we want to see an initial reduction. So we see that here. So Mojave County went from 7.8% to 6.9%. But just as important as that initial reduction is sustaining that reduction. So we can see, at least at the 6-month mark, and we'll have more data next time, that we've sustained that reduction at below 7%. So it's at 6.9%, which is great. Any questions there?
Any questions? Okay.
And just to jump in really quick, so I know that Aaron brought up that there's definitely some concern that we're not getting some of those high-risk candidates. But if you look there, the average A1C is 7.8%. So it is showing we are getting a good chunk of those that are nearing 8, maybe even some above. And the fact that they were confident about what they're doing, well, it's may indicate that they just weren't that educated on what their A1C scores meant at the time. So I think the data is showing that not only are we capturing some of those high-risk folks up front, but we are helping them reduce their scores.
Thank you.
Madam Chairman, may I ask a question?
Sure.
Are we since there's a low percentage or a medium percentage of participants, you're contacting new employees or new people that are purchasing the certain drugs. Are you going back and recontacting those existing employees that have a history of already purchasing the drugs for the diabetes?
No, we haven't yet gone back to resend to everybody who's already received a mailer.
And is that something that you intend to do?
Yeah, I could definitely see us doing that. Mm-hmm.
And possibly, if you do recontact those individuals, you can put in some of the successes of those people that are currently in the program and how effective it is.
Just running another marketing campaign, yeah, I could.
With some of the stats.
Yeah, with testimonials and.
Because you're missing those existing employees right now that have, for whatever reason, off the bat, chosen not to enter into this program. And I understand that we pay per head, is that correct?
Madam Chair, Mike, you mean for the program itself?
Yes.
It's based per participant, so if they don't sign up, there's no cost.
Right.
It's once they enroll.
But it's to our advantage, like you explained to us previously, that if they don't sign up and they're not managing their diabetes, in the long run, it costs us more than it does if they are. Okay, thank you.
And that's a really good, actually, Mike,
Thank
we
you,
never
Madam
thought
Chairman.
about that. That's a great recommendation.
Okay. All right, and on to the last clinical slide, and then I'll hand things over to Noah. So this is what we refer to as our likelihood slide, and there's a lot going on here, so let me just walk you kind of through what you're seeing. So overall, our goal as a program is to keep members in the safe zone for their blood glucose ratings. So that is a value between 80 and 180 milligrams over deciliters. And for what's happening with this chart is that it shows the likelihood of somebody being out of range on the low end, so with a reading below 80. And what you see is months are across the bottom, represented by M1, M2, M3. And Mojave County is in the green line. Livongo Book of Business is in the blue bars. And what we're doing here is we're using month 1 as a baseline. So we're comparing every subsequent month you see there versus month 1 to see if there is a decrease in likelihood with days with blood glucose readings below 80. So essentially, you want to see a decline every month. That said, the lines and the bars will bounce around a bit as more data is collected. What is important to pay attention to here is the overall average for the time period under consideration. And so for Mojave County, the average monthly reduction in the likelihood of days with a hypoglycemic reading is 46%. And once again, that is a very strong result. Typically, like for our book of business, it's at about 16%. So again, your population is responding very well to the program. Once we get more time and more data under our belts, we'll be able to show the likelihood of days with blood glucose readings above 180. There wasn't enough observability within the population to show that just yet, but that will be coming. Any questions?
Any questions? No, there are none, Krista.
Okay. Well, thank you, and I will turn this over to Noah to speak to our new hypertension program. And Noah, just let me know when you'd like me to advance.
Okay, and I'm wondering if you might be able just to transfer the controls over to me, and then...
Oh, sure. Let's see here. Oops. Sorry. You know what, Noah? I'm sorry. I'm not seeing a way to do that.
Oh, okay. Well, no worries.
That's a little funny.
Okay, so go ahead and click to the next slide.
Okay.
Okay, and so while Livongo started in diabetes management, from the beginning, our mission statement has continued to be helping all people with chronic conditions to live healthier and better lives. And so we started with diabetes because for a lot of companies out there and organizations, it was the #1 healthcare cost, and it was growing. And so that's where we started, but along the way, we knew that we were going to get into the comorbidities. And so the next logical one for us was hypertension. There's a much higher incidence rate. I mean, and it's typically, if not the top cost, top 2, top 3 in there as well. And also, we see about 75% of people with diabetes also have hypertension. So if we're not able to treat both, we're really not treating that whole person. And so about 6 months ago, we launched into the hypertension arena. So next slide. And so if you look at the cost here as we go through the bars, so, without any chronic condition, someone's not costing the plan that much. Hypertension, they're about twice as expensive. Diabetes is 3x. But then if you have both of those conditions, it just exacerbates even more. So even, obviously someone's health is most important, but if we're looking at those costs that an organization is going to absorb, it's getting out of control in a lot of areas. And so that's another huge reason why we really wanted to tackle this solution. Next slide. And Today, many people, it's one of the most common diagnoses when adults go into their physician's office is being diagnosed. But once you're diagnosed, it's challenging to properly manage that. And so first of all, just to measure it on a daily basis, it's inconvenient. It's rare that someone actually has a blood pressure cuff at their house. So a lot of times they're going into the physician's office once a week, once a month, and they're racking up claims for that. And also it's inconvenient. A lot of times people will go into a pharmacy on a regular basis, but then they're waiting in line. And so the idea that someone's going to be willing to do that sustainably for years to come isn't very realistic, and we're seeing that in the health results. And for those that are motivated to do this and say, hey, I'm going to get a blood pressure cuff at my house, a lot of times it's a silo of information. So it's not connected to anything, whether it's Wi-Fi, Bluetooth, or cellular. It's just giving them a score, and then they write it down. And so as you'll see, the second picture here is actually a picture or a page from a notebook that someone brought into one of our cardiologists on staff and said, hey, here are my scores throughout the year. And so while that's a step in the right direction, if someone had a spike 3 months ago, that data is not useful right now. That could have been a stroke or a heart attack that could have been prevented in real time if we're able to have that data in the right hands. And then just to quickly go over the other ones, just interpreting the data. So those that, are getting these scores back, how often does the average person understand what that means and what to do with that information other than just to take another pill? And so, really that lack of education is a huge area for improvement as well. Next slide. So our approach to this is extremely similar to what we're doing with diabetes today. So first and foremost, it starts with providing that super easy to use intuitive technology. So we've created a cellular blood pressure cuff, and I'll quickly show it here in the meeting. So as you can see, it consists of this device here, only one button on it by design. So it's really easy for someone to know to press it to check. You plug the cuff in here in less than 60 seconds. A member will have their blood pressure reading. Just as our cellular blood glucose meter works, it'll instantaneously transfer that data to their device, to their mobile app, but most importantly, securely back to Livongo. And so our coaches we have on the diabetes side, which are all certified diabetes educators, they've now been cross-trained into the hypertension realm as well. So for those members of yours that have diabetes today and hypertension that sign up to this, and they say, hey, I already have a great relationship with my coach, awesome. We're going to allow them to keep that same coach, and they can handle both conditions during one phone call. So rather than asking members, well, download a separate app, it's a whole different program. It's all one experience, it's the same app. So a member will now see when they log into their app, the one tile for their blood glucose, the next tile for their blood pressure. And it's just very, very easy to use. We're also partnering with the American Heart Association. That's where we're pulling in a ton of educational content as well. So in addition for a member checking their blood pressure, getting a score, we're going to give them real-time nudges based on what that number's coming in, giving them positive reinforcement when applicable, but more importantly, when their score is high, letting them know it's high, and giving them recommendations. If we know they're on medication, by them telling us when they sign up or from claims we're intaking, then we can remind them to do a better job taking their medication. And so helping to reduce those gaps in care. And really bring it all together with the 24/7, 365 coaching team. As I mentioned, same coaching team we have on the diabetes side as well. And so rather than members seeing a high score, and maybe in the past they were going into urgent care, going to the ER, now they know that they can connect with one of our coaches. So I'll pause there for questions.
Anyone have any questions? So this is another free service to the end user.
Correct.
In addition to their diabetes, the Livongo diabetes. And what about that monitor? How do they get that monitor?
Yep, so it's very similarly to the diabetes program. So communications would be sent out, and then they would sign up for this. And so we're going to have an intake process where we'll say, have you been diagnosed with hypertension? And then it'll come in a welcome kit, FedEx to their front door, just like the diabetes side. And then most people can figure out how to use it intuitively. As I mentioned, we have even pictures on the cuff. We only have one button on this device, but we do have a 3-picture instruction manual in here as well. And this is all included as part of that program.
And this is in conjunction with diabetes, it's not a standalone for people who only have hypertension?
Yeah, no, so certainly. So for our folks that have been rolling it out, it can definitely be for those that just have hypertension, but also those that have both diabetes and hypertension. And then those that do, there is a bundle discount that they'll receive for that.
Got it.
Yep. And we've seen a really huge adoption rate for those folks that have already been using the diabetes side, because as you've seen from your own net promoter scores, people truly love Livongo, and they get really excited to say, oh my gosh, now it handles another chronic condition of mine as well.
Okay. Any questions?
Madam Chair?
Yes.
Point of clarification, if I heard you correctly, I think you were under the impression this was a no-cost item. Is that correct?
To the end user.
Okay, you understand there is a cost
Yes.
for the, okay.
Yeah.
I wanted to make sure you had
Because
that.
we have new viewers now, live streaming, so I just wanted to put that out there. I think we're kind of forgetting we have new people watching perhaps now.
Understood. Now I understand. Thank you, Madam Chair.
Yeah, and then one exciting thing I want to mention is, so this was our initial device. Just from talking to members, as Krista touched on, we're constantly doing member feedback. A lot of our members said, hey, I typically use this, keep this at my house while I take my blood glucose meter with me. So this is something, in the comfort of my own home. And voice activation would be great. As we know, Alexa and Amazon is everywhere now, and that's how people like to communicate with technology. So we partner with Amazon. We're using their Lex technology. And starting in July, our next device will have voice commands. And so it can announce their blood pressure reading. It can say, hey, your blood pressure is high. Would you like to connect with a coach? And a member can respond to that. And then there's going to be just a number of different options. And certainly if they're doing well, giving them that positive reinforcement, but just making it even more user-friendly and tapping into those behaviors today that just a lot of people are already using. So just a really exciting development there.
Thank you.
And Crystal, we can go to the next slide. And so I mentioned we're working with the American Heart Association. One really cool area of validation for us was the American Heart Association selected Livongo's hypertension solution for their own employees. So we're in the process of implementing that right now. So it's pretty cool that the AHA members will actually be using Livongo. Next slide. And then some early results I mentioned, we rolled this out about 6 months ago. So we're already seeing some pretty significant reductions in folks' blood pressure. And we're seeing some excellent feedback there as well. So your members are saying that this is extremely positive. Our net promoter score on this site is 76, so even higher than scores that Netflix and Amazon are seeing on their solution. And I'm just seeing a lot of people. We have a Drive to 5 campaign, which is just a campaign to encourage people to test their blood pressure 5 times within the first 30 days of using this, to get them engaged, let them know how easy it is. So really compelling results. And we actually just had a press release last week that within the first 6 weeks alone, we're seeing some really significant reductions in blood pressure. And I'm happy to share that with the group afterward. And next slide. Okay, so that's all we got. So Krista and myself are happy to address any additional questions.
Anyone? No questions? Well, thank you very
Wonderful.
much.
Well, thank you for having us.
Thank you. Appreciate your flexibility on the timing.
I'm sorry, can you repeat that?
Oh, we appreciate your flexibility on timing and moving us a little earlier.
Oh, no problem. No problem.
Okay. All right. Well, thank you. Again, these results are great, and we look forward to our continued partnership and then seeing where we stand in about 6 months.
Thank you very much, Krista.
Okay. Take care. Bye-bye.
So, Madam Chair, we're ahead of schedule, but we went through your break. So
I'm sorry, say that again.
we're ahead of schedule, but we went through your posted break time. What's the trustees, would you like to stretch your legs? Do you want us to
What do you
continue?
think, guys? 5 minutes, 10 minutes? 10? Okay, let's take a 10-minute break.
Yes, dear. You're up. No, you're up. And then you're after. She's after you. Well, employer, it depends on the, yeah, exactly. Yeah, exactly. Are you trying to get, are you trying to display it? No, we went back, all we moved that.
And Hector won't be my clicker.
Hey, Chris.
You want me to click, or you want to click? Or do you want to stand, or? Yeah, this is all.
And what am I doing?
So. you
I'm
can just-
clicking with
yeah,
this or with this?
This.
Oops. Can they hear me that way?
Yeah, they should be able to.
Okay.
And I think this mic is on at all times, unless you hit the, maybe I don't know if you hit
It's
that button.
green.
Yeah, it's green.
Okay,
so-
where's my clicker?
So the other way. And then it's the one that's not showing. So go right.
And just point it anywhere?
No, just right in this area.
What board is that?
Delta Dental's board.
It is not.
We're at number 7, the Wellness Program Update.
Madam Chair, apologies, we're on the Delta Dental.
We're on the dental,
Yep.
but that wasn't what you told me earlier. That
That's
wasn't my
right.
fault, guys.
He said 6
Okay.
became 8
All right.
and 8 became 6.
We're lucky,
is
we're
the
very
way I-
flexible. All right, Delta Dental Claims Review, number 6 in your packet.
Good morning, Madam Chair, trustees. I'm going to go over the executive summary for the dental plans. There is a high and a low plan. So the first part of each one of the reports, we're going to be talking about the core plan, and then we go into the high plan, starting with the executive summary. For the core plan, 37% of your claims were focused in preventive and diagnostic procedures, which we like to see. Our typical book of business sits about 39-40%, so that could use a little bit of improvement. Your average claim payment this year was about $179.25 compared to the previous year's $183. And then your utilization rate did go down. So if you look at that filed annually was 4.16. I'm sorry, your utilization rate went up, but your average claim cost went down. Sorry, I apologize. So your previous average claim was 3.99, and this year it's 4.16. The per member utilization, which is everyone that's covered on the plan, did go up to 1.8 from 1.75. 98.5% of all your procedures were done by Delta Dental Dentist. So we like to make sure that everybody has access to a provider. There are 39 Delta Dentals that cover all the United States. There's no extra charges or anything for you having a national account. Basically, we provide access to all states. We share a national provider file. We just don't share each other's eligibility. And then the savings on the plan will go a little bit further. There's a little bit more description into it. We're about 35% of billed charges. The number of patients using the plan was 1,137, represented about 71%. And in the prior numbers, it was about 69.9. 1.3% of the members met or exceeded their benefit maximum during the year. Moving to the buy-up plan, the higher plan. Basically, this one has a little bit better outcomes as far as preventive and diagnostic services go. 47% of all claims were concentrated in preventive and diagnostic. Again, our book of business sits at 39 to 40%, so that's pretty good. Your average claim payment did go down in this case, down to 118 versus the previous year of 122. And then your utilization rate did go up. So again, the claim costs went down, but your utilization went up. So that's just kind of showing the savings that you are experiencing for using the in-network providers. Average 98.5% of the procedures were done by Delta Dental Dentists in this particular category as well. And then your savings for this particular buy-up plan was over 41%, a little bit over 41%. The number of members using this patient was, using this plan was about 59, a little higher than 59% of all the members. And the prior number was 60%. So it went down, and maybe they're not focused on needing extensive dental care, or they moved over to the core plan after open enrollment had happened. So this one doesn't even have less than 1% of the people meet or exceed their annual maximum. And we find that typically it's kind of interesting that dental procedures continue to go up. However, you never see a lot of increases in your calendar year maximums. Our book of business was typically sitting about $1,000 per calendar year. It's now around $1,500. So you're kind of right in line with the general population today. Your claims by coverage category on the core plan sits pretty steady. If you look at the pie chart down below, it kind of gives you the comparison from 2017 compared to the year 2018. I did see that your oral surgery in 2018 did go up a little bit, so maybe there are some older children in the population getting wisdom teeth extracted or something like that. Everything else seems to be pretty standard. On the buy-up plan, we do show, again, the pie charts below kind of gives you a great idea of where you're spending the percentage of your claims. So I did notice on this particular plan, your fillings did go up, but at the same time, your crowns went down. So that's a good thing, because obviously fillings are a lot less expensive than crowns. And getting your tooth filled or taken care of in an early stage is going to prevent you from needing to have a crown. All dental cavities are 100% preventable, so we want to make sure that people are utilizing the plan, especially if they're contributing towards it, to make sure that they maintain good oral health. And then you also know that the mouth and body connection, how important that is, because you do have a lot of unidentified, well, I shouldn't say, a lot of diseases can be identified just through getting an oral exam. They can kind of determine if somebody is in early stages of diabetes. They can look to see if you're going to be a heart condition practically. The plaque that's on your teeth is the same as the plaque that's going around your arteries. So you always want to make sure that you start out with good oral hygiene. Going into the dentist selection pattern reports, again, the core plan shows that your PPO providers are sitting at 86%, which is pretty good. And then the premier number of claims, you're sitting at 13%, which is 291 claims. Of these 291 claims representing the $66,520, these would be considered out of network if you were using another carrier. For example, Premier Dentists are exclusive to the Delta Dental family, and they do not accept other insurance. So it's nice, especially in the rural areas, to be able to offer this to the county employees, because then they can continue to go to their favorite dentist or find one that's close to them without having to worry about driving far or getting balance billed for anything over and above their allowable fee. Then you have about 1% of those people that go completely out of network, which is about 34 claims, representing a little over $5,000. And sometimes we just find that that is a result of a dentist just not accepting insurance, period, or he just has his own practice and doesn't want to take on any agreements with any other carrier, and or some people go out of country, for that matter, to get dental work done. On the buyout plan, again, your utilization in the dent selection pattern report shows that your PPO network is 94% of all of the claims, representing 556 claims. So that is a good utilization for you, because the PPO network gives you steeper discounts. It lessens the member's out-of-pocket expense, stretches their benefit dollar a lot further, and it also saves the plan money as well, because you're receiving those net effective discounts. For the buyout plan, there were 45 claims representing about $3,800 worth of Premier claims. Again, those would be considered out-of-network had you decided to go to another carrier. So we like to make sure that people are satisfied with the access points that they have. It's very important to them, it's very important to us, and we like to save you money on your claims as well. The next section of reports we're going to go into is the charges. Oh, I'm sorry, that's a mistitle. Charges by age, that's not right. Basically, this is the definition of a savings category of the reports that we're going to review the next couple pages down. So if you see, like in the middle column, they're going to be non-billable procedures. That's one of the line items that I like to point out, because those are procedures that are charged, cannot be charged to the patient or to the group. When you're using a Delta Dental dentist, it's just us managing your costs, making sure that they're bundling or unbundling claims. So if they're doing things that are saying, okay, let's do 10 x-rays instead of a full mouth, we're going to put it all together, and then they're going to have to write off any difference. They're not going to charge it to you, the plan, and they're not going to charge it to the members. So that's a nice write-off. When you go into this next page, where it breaks down all the dollar amounts, it also gives you a good representation of 2016, 2017, and then 2018. So a couple line items down. First of all, you're going to see that the PPO dentist fee savings was about 20%. The Premier savings was a little under 1%, and then the non-network as well. Your non-billable is $92,000, so 7.8%. So that's $92,852 we saved the plan as well as the members. Going, down to the bottom, to your net savings, total net savings throughout the year of 2018 was 57.1%. And if you look all the way across on the right side, you're going to see that it went from 55 up to 50, or I'm sorry, 55, then down a little bit, and then back up to 57 in 2018. So your overall savings was very, very, I think, based on our book of business, was very high compared to some of our other clients. In the buyout plan, the same thing. Your overall savings was actually higher. So your overall savings on this plan was over 70%. If you look at your PPO savings, 24%, and then going down in the middle of the page to your non-billable procedures, 12%. So $31,227, again, was just strict write-offs. The other parts of it, obviously, I'm not going to go through every line item, but the other parts are like non-covered procedures, your deductible, obviously cost sharing, the co-insurance. If 50% coverage was for a crown and the member paid 50%, 80% for your fillings or your oral surgery, for that matter. So that kind of breaks down and gives you a pretty good idea. In 2016, your overall savings was 63.6%, going up in 2017 to 67.7%, and then all the way up in 2018 to 70.6%. So very, very good savings. Any questions so far?
Anyone?
Yes, sir.
Okay, Roger.
Is there a trend one way or another towards more PPO or Premier, and does it really make any difference to the trust?
Good question. It does make a difference to the trust. We want to continue to recruit PPO providers because that is a savings in turn to you, but we still want to continue to allow members to have access to the Premier network. We close off membership requests to the Premier network and then open it up every so often. We have not recruited any new Premier dentists, but we have recruited several hundred PPO providers. So in the state of Arizona alone, we probably have 86 to 89% of all licensed dentists that are alive and practicing part of the plan. The reason why I say that is some of the provider directories that you see, they just list like all the dentists a couple times, or even if they hadn't been in practice for several years. We go through a credentialing process, and we carefully screen the dentists as well. So, thank you.
Any other questions? Okay.
Okay, so last year we talked a little bit about these health ENTIC reports, and we kind of had some side conversations with the wellness committee, the wellness people over at EAC, about trying to delve into some of the people on this benchmark report. This is the dashboard report. It's the first page of quite a lengthy report. I did not include the entire report. I just kind of wanted to touch on it a little bit. Basically what we do is we take 2 years worth of continuous eligibility, so it's not going to really capture new members coming onto the plan, and then all of your claims submitted, not necessarily paid claims, so that's why these amounts are not going to match the reports that we just reviewed. It's just for benchmark purposes. There's 22 Delta Dentals that participate in this plan, and we continually to get data into this big data warehouse so we can run these reports by group or by plan design or by groups within a trust. So if there's like several entities within one trust, we can break it all down. For this particular report, I did it on a national request versus by state, because I think that you get a better view on what trends you're seeing and what is going in comparison to your peers. The overall score for both plans for the county was about 58 over 100. So representing all the way on the left-hand side of the chart, it's the 38th 36th percentile, I need glasses, of the population. So we really, we're happy that you have 594 members that are, they measure healthy. 261 of those members needed moderate, so maybe they went for their annual checkup and they needed to get a filling or a sealant or something like that. And then the serious box shows that 240 members had not gone to the dentist and they just showed up on an emergency basis. So they got a toothache and they needed a root canal, or they got a toothache and they needed an extraction or a crown. So we want to take those serious people and try to move them into the healthy or the moderate category. The same thing with the no visits. The no visits represents 616 of your members. Again, excuse me, this is everybody that's on the plan, including children and spouses. So we can, we do have the ability to drill down into it, as you're going to see a little bit further down. So 616 members didn't even go to get an exam, cleaning, or x-ray. Why is that? We want to try to promote oral wellness. So again, it's going to help you bring your medical claims costs down as well, because if you're like the Livongo person or whatever was talking about, you know, you're managing your health, you're managing your oral health as well, then it's going to help you with your overall health. So in the healthy behaviors, if you look halfway down the chart, you're going to see the ages. We have like an age range of the members who received care, and then the total members represented in that category. So the same thing with the fillings and crowns, and then gum disease. So basically, we want to make sure that if you do have gum disease, maybe someone hadn't been to the dentist for a while, or it is genetic, it could be hereditary if you end up with periodontal disease, that you are going for your maintenance once you get your condition under control. A lot of times it's just a matter of just getting a simple root planing and scaling, trying to get your gums in a little bit healthier shape, and then maintaining that thereafter. I happen to be one of those candidates because I go 3 times a year for cleanings. So on the next page, this is where I was kind of introducing or illustrating the fact that we want to look at the members that had no visits. So what can we do about that? We can maybe send them some postcards. I don't know what the ROI would be for it, or if we worked with the EAC and developed those and sent those out. We can also say that we know that of these people that did not have any exams, cleaner, or x-rays, or did not even see a dentist who are enrolled on the plan, how many of those were employees? So maybe not necessarily focus on the children or the spouses, but kind of start focusing on the employees. So do like a little bit of an outreach program to them to get them back on track. Then the next slide just kind of illustrates, you know, the overall cost, what it's costing you. So basically we want to say that, you know, of your population, $111 less expense was made by those people who had their clean exams and x-rays compared to those who did not. So we want to make sure that we try to increase that number from having, like I said earlier in the reports, it did show that crowns went down a little bit, but fillings went up. But that's okay because fillings, again, are less expensive. Sealants, I think I talk about this all the time. You may have heard it before. True story, I have like 2 age groups of kids. I have kids that are older, like 9 years older than the younger ones. And my younger ones had sealants, and they never had a cavity their whole life. So it does show that, you know, the case for prevention, restorative costs, or whatever, it does save you quite a bit of money, $74 less per person, if those people are getting their sealants done. Another nice feature about the plan is, unlike some of the other carriers, we do allow sealants to for permanent molars and bicuspids. And then we also allow it to age 18. Some cases it's only to age 14. So you want to make sure that they're getting the coverage that they need. On this slide, no follow-up. So basically, somebody went to, they had restorative work done, but then they fell off track again, and they didn't get their clean exams and x-rays. The same thing with perio. We want to make sure that there's other ways that we can focus on those should you decide to go into something like that. But I just wanted to do like a brief summary of what this lengthy 18, 20-page report kind of looks like, so you get a feel for how important oral wellness is. And then this page just kind of shows like the recommended outreach groups. Basically, the one furthest on the right to the bottom, adults with 2 years, no visit. In most of my clients, we start there rather than perio or children or serious members. So we want to start there because what they do is they're called health impact programs that they offer. Basically what they do is they kind of incent somebody and say, hey, as you are the vendor, can you give us some raffle prizes? Can you give us an electric toothbrush? Or so when they're showing you that they had their clean exam and x-ray done, they're also being entered into a drawing. Some of our clients give them a premium holiday, or they have a little reduction in a rate, kind of like your medical would be a smoker versus a non-smoker. Some of them have a point system, so along with maybe their mom or their pop exam or their biometric screenings, they can enroll in this plan and then basically get a couple points for it, and then whatever you decide is their rewards or awards would be their outcome. We do see when we first implement a group into this type of program, you see your claims utilization go up a little bit, but that's only because you're finally touching those people that had not been to the dentist for a while. And that's okay, because it's going to go up, but it's also going to go back down, and then it's going to maintain and maybe even go lower. So your utilization might go up, but your claims costs are going to continue to go down as a result. And then it typically spills into the medical carriers as well. Any questions on that? Anybody? I'm keeping everybody from lunch, almost. So then the last part of my presentation, I would be remiss if I didn't tout about our wonderful customer service and our claims processing. Again, because we carry the Delta Dental national name, we are required to have strict performance guarantees, and then we make them a little more strict for us here in Arizona, because we rather under-promise and over-deliver. So our customer service, our average speed answer is about 19 seconds. Our claims processing happens in about 3 calendar days. This is probably more of a result of our system setup. So when we implement a group, we have a drop to pay rate, which is about 85%, meaning that the claims that come through the system require little to no intervention. So they just go through. We also have our dentists are set up on EFT. So as soon as their claim processes, their money hits their account. They love getting paid earlier on time, and so that helps as well. And then we also do audits. So we do group-specific audits, and we also do audits based on our book of business, just to make sure that we're up to par with our financial accuracy and our claims accuracy. We also include, believe it or not, predeterminations, because when you want to have work done that's over $200, it's important to know ahead of time, is it covered? How much am I going to be responsible for? So we like to include that in our turnaround time as well, because you, as the member or the patient, are waiting to see if it's approved so you can go get your dental work done. You don't have to wait weeks and days and months to find out. The other thing that we measure is our enrollment processing time. We have both EDI group, electronic eligibility groups, and we have paper groups, believe it or not. So we want to make sure that those are getting processed on time. We do have several groups that submit weekly files. We try to get those done within 3 days. Most of the time, our files are loaded the same day they're received. The average accuracy of, and the I'm sorry, the average days to produce the ID cards is about 7 days. So people like to have those ID cards. You don't necessarily need to have one, but they just like to have them in their hands. Any questions on my presentation?
Anybody?
We're good?
No, thank you.
And the good news is the renewal is going through with the spoiler alert that happened this morning. So we were excited about that. And thank you for your time. I'm looking forward to another year.
Thank you very much. Okay, now we are going back to the wellness program. Am I right? Okay.
All right. Madam Chair, members of the trust, thank you for having me here today. I am Jane Merlino. I'm a wellness consultant with ECA and filling in for Missy, like Erin said. So I'll be going over the wellness program review from last year. So today I'm going to be covering the health snapshot, which is just where we go through the medical claims, chronic conditions, and health risk assessment data to see where our what's really driving the costs of our claims and what we're able to target with wellness. I also snuck in the pharmacy claims in there too. We have the wellness program review, which is the previous 2 years of the wellness program. First year, as you remember, we implemented the on-site screenings, and second year we brought on the Livongo program. And what's coming next is the third year of the wellness program, and we're bringing on Walker Tracker, which is just that technology component to addressing chronic conditions. So as I said, the health snapshot, this is just going into the claims, looking at all the data, seeing what we need to address and where we need to possibly shift our focuses. I have the medical, pharmacy claims, chronic conditions, and health risk assessment data. So for this first one, the medical claims, it looks like a lot of information going on, but what you can see is the categories at, which are costing the plan the most money. So what we see when we look into this is diseases of the musculoskeletal system, circulatory, and neoplasms as areas that we can affect. There's also factors influencing health status on there as number 3, and as Rick mentioned, that just kind of means that people are participating in these preventive services and taking care of what they need to do. So for the chronic conditions, chronic pain's number 1, but it's not necessarily addressed directly by wellness. So we focus more on hypertension, diabetes, hyperlipidemia, which are highlighted up there. These are all lifestyle-driven conditions that we can really address. So bringing on Livongo has helped with the diabetes and with the co-occurring morbidities that go with it. We focus here also coronary artery disease, not highlighted, but that usually comes along with the other 3. This is another reason right here is why we're implementing Walker Tracker, is to address these. All right, so this is the pharmacy claims information, the top 10 therapeutic class for the fiscal year 2018. As Erin said, anti-diabetics are number 1 on that list with 116 utilizing, but that doesn't necessarily mean it's a bad thing, because if people are being compliant and adherent with their medications, then we like to see that. This is where Livongo was implemented in order to target this area. Other important categories that are on this list but not in the top 10 are the hyperlipidemics and anti-hyperintensives, because those are relatively inexpensive, but there are a high number of utilizers. All right, so for the health risk assessment, This is the yearly blood draw that comes at the beginning of the year. We just had it a month ago, but this is the data from 2018. I haven't gotten the 2019 yet. So you'll see all below in this little chart are the different risk factors that we look at. These are the risk factors that contribute to metabolic syndrome. And metabolic syndrome is when you have a combination of 3 or more of these risk factors. So based on the data we had, we really didn't have a lot of participation. So we only came out with seeing 16% of members with metabolic syndrome, which is pretty low for the national average. And especially compared to the pharmacy and medical claims, we think those numbers are actually higher from what we're seeing elsewhere. So basically, this is like the worried well participating, and we need to just target some more in the next year to get more of those high-risk members out and getting their numbers and being aware of their risks. So into the wellness program review, the first year we implemented the on-site screenings. So now we have 2 years of screenings, and last year we implemented Livongo for diabetes in July, so we have the first 6 months of that information to report on. So for the previous 2 years of on-site screenings, this is an overview of all screenings. There's, in the appendix in the back, is a breakdown between each screening, their screening location, and results, so you can get more detail on the participation results for each of those. What we saw in the second year was a really good increase, especially in skin cancer and cardiac and organ. We had to keep extending times and adding locations, especially for public works. We were really filling up, so that's a good problem to have. For this year, we have skin cancer coming up in a couple weeks, and we added a couple more dates and just added more time so that we are able to accommodate all screenings. And cardiac and organ will be coming up again in about September this year. So for the HRA, like I said, we'd like to see some more being screened just because it's a really important screening, just contributing to your lifestyle risk factors and what you can change just with diet and exercise. Mammograms, we saw a good increase, but overall, only about 23% of eligible utilized those on-site screenings, so we'd like to see that number higher if we can. Prostate exams, we will just continue to struggle with this on all accounts forever. We can never get the participation we want. Last year we had 5% eligible, but we're doing what we can, just implementing more marketing flyers to get the word out there on the importance of the screening. Vaccinations went up. This is accounting for just flu. There were too many pneumonia vaccinations given, so I didn't want to kind of skew that a little bit. Healthy heart blood draw, you see we had that one first in 2017 to 2018 year, and we took it away last year just because we didn't see the participation and the need for the screening if no one was going to go. We're going to bring it back this summer to be a mid-year check for those on the Livongo program and anybody else who wants to get their numbers, but now we just see more need for it with having Livongo, so that those members are able to just kind of check in and at least get those 2 checks a year on site here. All right, so Livongo, they pretty much touched on this when they were here, but everything has been going better than the book of business so far. So we had 43% enrolled in the program, and 89% of those were activated in the program. We would like to see, the target is 60% of diagnosed diabetics on the plan to be into the program. So we're doing right now is the mailers home for anybody who fills a new diabetic prescription, and then looking into if like another marketing program to get more push out there, and then we do promote it also at open enrollment. So we have for the early results, again, better than the book of business. We saw a 0.9 decrease in the estimated A1C in the first 6 months, and Livongo book of business is a 0.8. So overall, we'd like to see a 1% reduced just to reduce those risks of complications that come with diabetes and non-controlled glucose levels. We'll have more thorough evaluation on the program later on. It's just, for 6 months, early results doing very well. So the marketing strategies, like I said, open enrollment and mailers to homes for members filling prescriptions. The survey results that we've seen have been overall positive and above their book of business survey results. So, all right, so what we have next, Walker Tracker, which is just the third part of that wellness program being implemented this year. So what it is, it's a wellness platform that promotes activity, it tracks your lifestyle, mood regulation. What's really neat about this one is that it accepts all major device brands, so it's not limited to just Fitbits or Apple Watches or Samsung. So everybody is able to participate. There's challenges and just a lot of cool stuff with the platform. So we're excited to roll this out July 1st. We're currently working on the contract with Walker Tracker, and then we'll get with the committee and figure out the solid plan to get this out. Do you have anything else to add on Walker Tracker, Aaron?
Yeah, thank you. Madam Chair, members, what you're seeing here is you're actually seeing two themes basically in here. When you look through the data going back to even when Rick started in Livongo, this program, when we looked at the claims, is they're all heading for some variation of that idea, that metabolic syndrome. Frankly, the only problem with any of the numbers is they kind of look like silos, but medical claims don't exist in silos. They tend to come in clumps. So this program that Jamie's talking about is the third element from what our original contract was, which was to come in, rejuvenate the wellness committee, which I have to tell you has been fantastic. The folks have just responded so well on that. So get that done, get the screenings implemented. We switched things up because we were originally going to do something like Walker Tracker in year 2, but we eyeballed that diabetes issue, so we reversed it and did the chronic disease state management first. And this is the third component, which is the Walker Tracker. And what you're seeing is we're targeting through activity with this in a fun way, a voluntary way, a way for your employees to group in teams. They can create interdepartments, courts against the cops, against the jail, against the board of supervisors, to get them. And the idea is just get them up and moving. Just get some level of physical activity to break that chain of these kind of intermingled disease states. And the second thing you're seeing is a progressive move towards individual technology, which gives us better data. And ironically, it gives the participants greater anonymity because no one's seeing it except the electronic means that it's being communicated on. So we get much more reliable data that we can measure effectiveness with. They can measure their own activities individually and against their peers, and all together it targets back at those clumps of disease states that drive the claims. I know that's kind of long-winded, but it all fits together into a jigsaw puzzle that's targeted at the areas that are driving the claims for the trust.
Okay. Any questions? Yes, Roger.
The on-site screens, it seems like a lot of them don't do the ultrasounds, and yet that picks up the potential for strokes, for a lot of people. Has anybody took a look at that? I mean, it's a very simple process, but a lot of screenings don't do it.
Yeah, we have the cardiac and organ screening. That's the one that comes on over summer, and like I said, I think it's scheduled for September. But that does the ultrasound of the thyroid, the abdominal aorta.
PAD?
Yeah, it does the
Pulmonary arterial.
peripheral artery disease,
Peripheral artery disease, for sure.
coronary, and it checks on liver, pancreas. So yeah, that's the ultrasound screening. Yeah,
And that's one of the ones we had to add, ironically, especially again, we were talking about public works, but that's when we had to add additional slots because it overwhelmed all of the budgets. We had to add slots at the beginning and the end of the day. And particularly for a first run program, that was excellent.
Boy, that's great. Thank you.
Yeah, can I add on that? Because I did that. I was adding it last minute, and it was really, really successful. And I think because the word of mouth was because we were given a report like a booklet, and so we could follow up when it happens next year. We get to see, we were given what we need to do, and then we can track that. So I thought out of all of them, that was pretty much the most successful one. I have another question, well, not a question, more of a comment about the on-site like mammogram. So I just want to give people a false picture. It doesn't mean that people aren't getting them. I mean, there's still a lot of women are getting them when they're scheduled through their doctors and things like that. It's just if you happen to need it when that mom's thing is available. So it's not a true indicator about who's getting, and I don't know about the prostate thing. If men are getting it through their doctors, I have no idea.
I don't have those numbers.
Yeah, well, Madam Chair,
I'm not looking at you for any other reason.
on the mammogram specifically, and you're correct, because it depends on when you're here. We can do things like waive that timeline through the vendor to have them come on to reestablish, because the cost of doing the mammogram, and I will tell you, they're all 3D now, so it's identical between the locations, but the cost is something like 25% of what it is on a hospital-based clinic. So everybody wins if we do that. The prostate one is a never-ending battle, and I can't say this one because I'm a guy who's eligible for the exam, and I hate it too. But it's really tough to get the guys to go do that exam. So we looked at the win that we had and the fact that it was in a male-dominated department, Public Works, and we thought if we're going to get uptake on other screenings, that perhaps the positive response we got with the skin cancer screening, because a lot of those folks are outside, the flood control guys, the engineering guys, the road guys are out there exposed with a lot of their skin. If they got comfortable, we're hoping to see an echo effect on the other side, because across our book, across the state of Arizona, the prostate screenings is the highest abnormal percentage of any of the screenings. It's consistently north of 25% are abnormal. So that low number to us represents a failed effort that it just got to overcome the resistance from the guys to go do that 20-minute exam.
Mike, what was the incentive we gave to Public Works this year? Do we give any incentive no?
I don't recall.
Oh, okay, because I know that there was some kind of effort made. So maybe we need to revisit that. Okay, anyone else?
I have a question.
Yes.
Actually, I have two questions. How much, I think, I remember a few years back, we had a case with a gentleman that had breast cancer here, and how much of that is there actually around when it comes to, does it tend to be like heavier people, or what's like a indicator of me? Frankly, I don't have nothing there to have breast cancer on, so I'm just curious.
I don't really know the risk factors offhand. I know the percentage is really low of men who do get breast cancer compared to women, but I'd have to look at what the actual number is. Yeah.
Yeah, and then the second question I had was this mood tracking thing. Is this voluntarily and selective or what?
No, yeah, you just
the
enter it
paranoid's
in.
coming out of me here right now, so.
Yeah, it doesn't know. You have to enter it in to track your moods.
Okay,
Yeah,
thank you very
that'd be a
much.
little too much.
And as far as the fitness, and I hear it anecdotally from different departments, from directors, from attorneys, they really like that sort of competitive thing where they're walking in their steps and, hey, guess what steps I did today? And it makes it fun, and that's what we foresaw. That's what we tried to do all those years ago when we first started talking about the wellness, that it had to be something, it was like, attraction, not a promotion.
Yeah.
And I think it's worked.
And that's what's fun about this program, is that you can customize your challenges and kind of make them what you want. So you
Right.
know what your members are going to participate in and have fun with doing.
I might even do it this time.
Madam Chair, we're doing it internal to ECA. We've done it. We have a thing called the Zombie Challenge, and we're actually challenged against our clients. And you're being chased by zombies, and you get power based on steps. And it's ironic, in our office, you keep hearing the darn thing going on, and we're all playing it. So I don't know about the productivity game, but it's got us all up and moving, and we're again competing with our clients.
Very much.
Thank you.
All right, are we done with the wellness? And after talking about all of this stuff, we can eat now, right? It's all healthy stuff, right? Okay, so we should adjourn, and, you need to say something?
No, I was just going to say lunch is ready, so it'll be in the same place that breakfast was at.
Okay, so we have an hour. We're going to break for lunch, and we'll meet back here it is now 11:42, so let's say 12:45, we'll meet back here. Okay? Number 9, Employee Assistance Program and Substance Abuse Mental Health Carve-Out Plan.
Yeah, Madam Chair, with your permission, I'm going to tee this one up with Mike, or for Mike. So there's two things in here. Mike is going to do the presentation on the current utilization of the Employee Assistance Program. And then we've asked him and included in the budget a recommendation to reconfigure how this program works. It's based on two things. It's based on what our experience with other counties around the state, kind of tying into both mental health and substance abuse, and then also responding to what we're seeing in some of the claims data. So I'll go into, when we get to the budget, I'll explain how we actually did it. So on the EAP side, I'll leave that to him. But what we're proposing, pardon me, on the mental health and substance abuse side is to carve out the case management for those issues. So beyond addiction, serious mental illness type things, to carve that out of American Health Group, which does the more traditional hospital and MD type care, and to have Holman Group take over and become a separate case manager just for those issues. And the reason we're doing that is there's a serious problem in the state in terms of availability of mental health and substance abuse providers at every level, inpatient, intensive outpatient, straight outpatient. And what we have seen over the years is that employees who seek those levels of care beyond what's available through an EAP struggle to get in. So they're gatekeepers, and they become a tour guide to help them get into an appropriate level of care in the Blue Cross or the Aetna network out of state. Secondly, for emergent care that we see, and you even saw it in one of the cases here with Rick's numbers on the case management side, for urgent care issues, I'm talking crisis care that goes through the ERs, the emergency rooms, and you could think of severe psychological events or opioid overdoses, which are common again nationally. The ERs are built to deal with those acute episodes, get them medically stable, and then kick them out. Okay, there's nothing wrong with that. It's what their model is. The problem with that when you're dealing with addiction issues is there's literally no element in there to provide for follow-up care. So what we're looking to do with this, and what we've done statewide with our county group, is give employees who find themselves in that situation, they understand that they or their family have these severe issues, or they become aware of them, as many parents do when they get a call from the ER that their kid overdosed and got Narcaned and then transported to the ER, gives them a place to call that has highly focused expertise on dealing with those issues, so they can channel them into a level of treatment care where basically increase the odds. There's no guarantees, but you increase the odds. And the backstory on where this came from is we have a pool of 6 counties that we've run since 1994. And starting about 6 years ago, we saw the uptick. And what we were seeing was, for the most part, we were seeing severely addicted kids, typically multiply addicted. And what their parents were doing in acts of desperation was just putting them in whatever place they saw on the television most recently. And those places will run $30,000, $40,000 a month. And they were out of network. So you're literally, and without exaggeration, talking about people mortgaging homes, raiding 401ks, anything to get the treatment. So we didn't know. So what we did is we contracted with Holman, same situation we have here, and carved it out. And in our first 12 months, we had 13 cases go through, just on mental health and substance abuse. And it was more than we actually expected to see. We had spouses, we had kids, we had opioids, we had meth, we had alcohol, we had severe psychological conditions, and it gave them a resource they could go to that was specifically expert in those areas and channel them in. What we see on Mojave's experience is the same kind of things we now recognize, which is a relatively high utilization of opioids, of benzodiazepines, and those two are kind of indicators. So especially when you see them outside of those end-stage cancers we're talking. So, and then following up, we see in your, and Michael touched on this in his presentation, we see in the EAP utilization the indications of some, frankly not rare, pretty common, psychological conditions, mental conditions, some transient, some serious. And we think that if we try this, that we'll have the same experience we had with our counties. What I expect to happen is if you do this, and it'll be in later in this afternoon's discussion to show you how we priced it out. I think what we'll probably see is there, as we've seen elsewhere, there's probably a fair number of cases, maybe 8, maybe 10, maybe 12 that exist that don't have a place to go. We'll see them come through in that first year to 18 months. So maybe we'll see those dozen cases go through, and then we see, I'm guessing we'll see it stabilize 4 to 10 a year. whatever the number is, depending on how it goes over time. But the whole intent of this is to provide those employees who have this issue in their households or in their personal lives with a highly focused vehicle to get them into the appropriate level of care in network.
Okay, you're kind of in my wheelhouse now. So with AAP, so how I understand the programs is that the patient has to go to an AEP specialist, somebody who has the credentials to assess them, first of all, like in any one of these programs. And the problem in Mojave County is that up until now, pretty much, there hasn't been any. There's no one to go to that for private. I mean, a lot of the money goes to access providers, not to private. We've been successful in putting together a drug treatment center for women in Bullhead City that will be open probably by the end of the year, and that will take private insurance, but that's the problem. So what you're going to be doing is you're just going to be sending people out. I mean, do you have the network? I guess I want to know if you've done, and I'm sure you have, but done the research in Mojave County to see what kind of facilities and help is out there, because we have a huge lack of addiction and mental health services here in Mojave County.
And Madam Chair, you're exactly right on two counts. First off, it's easier if you're an access patient to get to care, because I was actually the president of the Mojave Mental Health Board for a number of years. I was on the board for, I think, 10 years. So it's easier if you're on access to get to mental health. They have a staff of over 400 countywide. They can't accept private pay, okay? Secondly, there is a lack of private sector providers. So my expectation is people will be going out for certain things, intensive outpatient possibly, and inpatient stays specifically. Those are the downsides. The upside is you have an Arizona-wide network that has Blue Cross providers, and because you have the Aetna wrap, they will have people in Las Vegas and in other areas where they could go. The key is to get them in network, because if you remember, we have no out-of-network benefits. That's a huge financial detriment to getting treatment.
Right.
So this is directed at giving them, again, that call these guys. It's beyond the EAP. The EAP really becomes kind of an entry point, secondary to its primary function, but it becomes an entry point to getting that specialized care so they can help the appropriate level of care in an appropriately credentialed in-network facility.
Right. And so the reason I'm telling you this is because it just came to my attention that we will finally have an AEP certified counselor who can do the intakes, because we haven't, as how I understood it. And that we will have some facilities and hopefully more coming. But when people go through this, and even they're sent out of state, so there'll be a case manager, because that's where it all falls apart. After they go to treatment and there's no support, they come back home, best of intentions, and it usually falls flat. So you're saying that this case manager will follow them even after treatment?
I'll let Mike speak to that, but that's the intent. There's a point where you take them off case management. They get stable, whether it's medical, psychological, substance. There's a point where people come off because their case management essentially becomes that provider. But I can let Mike address that because his entire profession has been wrapped around this. So I think it'd be more appropriate to let him do it.
That the segue? All right. Well, Madam Chair, members of the trust, good afternoon. It's great to be here with you. This is my first time to join you in one of your meetings, and I've been with the Holman Group for, I guess I'm close to about a year and a half in a couple of different capacities, and just quickly of late, in the last several months, I have had sole responsibility for our business in the state. Both our employee assistance business as well as our managed behavioral health business here in the state, which crosses both public and as well as the commercial sectors. It's growing for us here quite dramatically. I'm responsible for growth as well as major account management. In fact, we're looking for another account manager because of the growth that we've experienced here in the state. So we're thrilled to be here. You originally knew the Holman Group is Holman Frazier, which was our Arizona company. And the Frazier part of that was Larry Frazier, who chose to seek the good life of retirement. And so my coming on board, at least in this capacity in the last several months, was to replace Larry's role. I could never replace him, but certainly his role. And we made a name change. So you'll know us as the Holman Group of Arizona, and we are a, very much invested in the state in doing what we're doing here. As Aaron said, and it was a tremendous introduction, is we've had the pleasure of being the Employee Assistance Program to the county since mid-year 2016. So we're now into our, I guess, after about 2.5 years, and I'll show you some of our utilization over the course of that period of time. And then also looking at a case management program or a managed carve-out, if you will, for the behavioral health services and those that are seeking higher levels of care. Rather than jump into that now, I'll segue into that as I go through first some information about our utilization and the EAP program, which I think you'll be very impressed with. I was impressed with it when I looked at the statistics over the last couple of weeks or so. So if we move on into the presentation, the first slide next slide talks particularly about the Holman Group. We're crossing our 40th year in being in the business of employee assistance. We have 24/7, 365 call center capability at any time of the day for both routine activity as well as crisis situations, and we'll talk about that workflow as we move on in the presentation. We've got a relatively robust network here in the state as well as across the nation because people do move or they've got dependents or others elsewhere around the nation. We've got to ensure that they have access to care. So we do have a fairly robust, if not the largest network of behavioral health professionals, particularly those that service EAP, which is unique to those other entities. You mentioned some of them that serve the public sector and other populations around the state. And I will tell you, Madam Chair, you asked great questions. Access, access, access are the top 3 problems in behavioral health across the country. Period. It doesn't matter. I've lived in multiple states across the country over my many, many years in behavioral health, over 30, and this is my business, and I've crossed that issue everywhere we go to ensure people have access and timely access. Trying to get into a psychiatrist these days is sometimes almost impossible when you need that kind of help. But we won't go down that path. That's another day for all of that. Next, we talk about the services, and this is, again, just pretty much a summary on the next slide. Oh, I'm supposed to do this, aren't I? There we go. I'm a little slow. I'll put this in my hand. That might remind me. Is the EAP and then the managed carve-out business, and I talked a little bit about that already. Current and future state is your employee assistance program. We also have incorporated House Bill 2502, which is the first responder legislation. I'll talk a little bit about that later in my presentation. I know you've got a unique situation right now with law enforcement and services that are serving law enforcement officers outside of the EAP. But one of the pieces that we've done as a supplement to all of our EAP programs is ensure that we are being sensitive to first responders and public safety personnel around this new House bill that went into effect last year. And then, as Aaron introduced, the proposal to look at a case management program under the Managed Behavioral Health Program. We have a 6-session model currently for the employees of the county for not chronic or serious mental health issues. These are typical issues that I think we experience daily through just daily living and our work-life environment and so forth, and ensuring a balance. It could be parent-child issues, it could be marital conflict, does get into alcohol, drug abuse. And in that 6 sessions, we want to at least get people the help they need, a resource that they can talk to, and work toward solutioning in that respect. It does include, as I said, again, being somewhat repetitive here, it does include the face-to-face sessions with a licensed therapist, up to 5 sessions. Looks like they did one of those things with this. Our critical incident stress management is something that is very common in the employee assistance program. It's not, a day doesn't go by where one of our clients somewhere around the country doesn't have some type of critical incident that they want a resource out, and they may want that resource out that same day or within a certain time frame. It could be something as we may perceive as simple as a reduction in force or a change in an employee pool, and that has an impact on the existing employees as well as those that might be departing their place of employment, to something very serious as we see today, workplace shootings. We have a lot of banks in our portfolio of clients. You know, it could be a bank robbery. It could be the death of a peer or of a supervisor, or a tragic situation that may occur. We've responded where young women have given birth to a stillbirth baby, and that's had an impact of everybody around because they kind of lived with this person through the 9 months of this person, 8 or 9 months of this person's pregnancy. So we have specialists throughout our network that will respond. They contract us to respond in a very rapid sense to help employees around whatever incident may have occurred that they needed assistance with. We had, I think you have a public works official here, for example, in one of our markets here in Arizona. There was a school nearby, and a young child broke loose and went into a workplace, into a place where the street was being worked on and was struck by a vehicle. Affected all the public work material, all the people that were working in that particular environment. It was tragic for them. So that's kind of what we do around our critical incident stress management. I could talk a lot about that. We have dedicated people that is solely what they do. One thing that's unique with us is we're on the ground here. We have myself as well as others that are here to respond as we need to various events as an account management team. And then several services that we offer as part of the Employee Assistance Program include the Life Solutions Program, Global Fit, which you have. The Script Save card is something that's available on the website. We'll talk about the website, which is a discount program for certain pharmacies that's there, as well as our legal and financial counseling services. I can show you the utilization on that. We do attend employee orientations and health fairs, and I think one of my peers actually came to an open enrollment event, I think last year. For example, we're very accessible to that, to you, to be available for those types of events. And then our website, which is going through an update actually, is very robust and available for a lot of different resources for people to look at. We have two different means, as I mentioned earlier, our routine intake process. I won't spend a lot of time here because we've got a lot to cover in limited time. But when a person does call, they will get one of our care access specialists. They'll do a basic intake. Our commitment and what sets Holman apart from other organizations is once we know what the issues are, we reach out to a provider that best matches them. They may want a provider that's closer to home or to work, or a male or a female, or whatever it might be. We match that need, and then we reach out to a provider to call the member to schedule the appointment based on their availability. We found that to work a lot of the time. If they don't hear within a couple of days, we ask them to give us a call back. But our commitment is that they will have an appointment with a provider, having scheduled with a provider within 5 days of that initial call. The crisis intake process is a little bit different. If a person is in crisis, they may be in a vulnerable situation. They may be feeling a threat to themselves or a threat to others, or whatever that might be. They are immediately transitioned to one of our licensed clinicians who's available 24/7. They work through what they can on the phone and then get them into immediate face-to-face care, either the same day or the very next day, or if it's a very urgent situation, involve EMS if that's necessary. But that, I've actually tested that in the middle of the night at 2 a.m. If I'm not sleeping, that's my crisis, is not sleeping at 2 a.m. a lot. I just picked up the phone, I called to see who answered the phone, and sure enough, they sounded awake actually. We didn't wake anybody up out of bed. And they're available 24/7 for crisis situations. As I mentioned, the next slide talks about our access to services, both through not only the telephonic capability through our 800 number, but also you can access resources through our website. Both your benefit information, it is customized to Mojave County. We have feedback forms, satisfaction forms. We actually offer a quarterly newsletter. We offer webinars every single month on certain topics that are on the website. We really want to get people familiar with that capability so that they can see what resources are there. And if they want to plug into a webinar or into a recorded event on a certain subject, they can go onto the website and access that information. Again, you've got your own customized username as well as password for all of the employees, which are posted there. If you're looking at what showed up in your package, that came from another presentation, and that's wrong, but this is the correct one. Other services that I want to point out here that are not part of the portfolio currently under the EAP program with Mojave County is our identity theft program. Anymore, as you know, we're at risk of having our identity thieved in one manner or another. This is a service that is offered, a 60-minute free consultation, for example, with a fraud resolution specialist. They have an 8-point emergency kind of kit and resource kit that a person can use and access and resource to protect themselves around identity theft risk. Really try wellness because of the wonderful wellness program that you currently have and that's available as another service that we have and we do offer. It wouldn't really be applicable in your case. And then brand new right out of the gate is our absence management program and software package, where we have a technology to track absences, any kind of absence that might be there. We know how that can impact a workplace in a lot of different ways. It's both voluntary as well as mandatory absences. It tracks FMLA, maternity leaves, and the like. It has a absence management return to work program as part of that package as well. And we do have some trainings on that, and we just rolled that out after the first of the year. I segue now into House Bill 2502, which is the first responder legislation that was passed on April 23rd last year. There were a couple different renditions of this. This is where, beyond the initial 6-session model, and some it's as low as a 3-session model, for example, it does expand that to a 12-session model for first responders, at least initially out of the gate, as well as public safety personnel. Includes peace officers, firefighters, EMS, police, sheriff, and the like. With House Bill 2502, that was actually expanded for first responders to expand the benefit to 36 visits beyond the initial visits that they have as part of their package, in your case, a 6-session model. So it can go up to 36 visits, and that is allowed if a mental health professional, a licensed mental health professional, determines that they need care beyond the 12 initial expanded visits, if I didn't confuse you too much there. So if that happens and those visits occur within 1 year of the first visit, then they have up to 36 visits that they can have, and there is an additional charge for that, and we'll talk about the charges for that go over and above the benefit. So in your case, from 7 to 36. In the case of first responders, or 7 to 12 in the case of other public safety personnel. Let's see. There it is. There's the pricing. I knew I had a pricing page on that. So for that, for the House Bill 2502, it is $150 per session that is charged for that service. And then I talked a little bit about our crisis incident debriefing services. There's a charge of $150 depending on the location and how far we need to bring a person out for that, whether it's rural or urban. If there is someone local, we would consider that the lower priced case, as well as a transportation fee for those two services. Now, we look at your utilization. I have to tell you, I was really impressed. In fact, Mr. Cunningham and I were having a brief chat before the meeting today, and his first comment to me was, people know about your EAP and people are utilizing EAP, and that is music to my ear. That EAP is actually not a foreign acronym within the county of Mojave. I got to tell you, Monday I was at another consortium of public entities on the eastern part of the state, and they had a resounding 0% utilization in 2018. It was tough to see it, just maybe a little north of 0%, well under 1% utilization. And with these 5 or 6 people that I was in a room with, it was all about what can we do to promote that. That doesn't serve us well. It's not serving you well as executive, as your particular organization. It's also not serving your employees well, that there is a service that's out there and they're not utilizing it. And we talked, we spent a good deal of time talking about what we can do to promote the EAP within their respective organizations. But in your case, as you can see, the first slide shows the first 2 quarters of 2018 really looked quite good. As you saw, we saw quite a bit of growth, particularly on the EAP. We're not seeing a whole lot of usage on the legal and financial benefit. The legal benefit is one where you have a 30-minute consultation with the lawyer to determine needs, and then a 25% discount with one of our network lawyers that we contract with for continued services. Financial services, similarly, is a great service that offers with estate planning, will planning, anything and everything is around budgeting. That are available through our network. We use Consolidated Legal Concepts, which is an international, global resource with, as I said, lawyers, paralegals, and financial counselors throughout the nation that people can resource for those services. You've had some utilization, as you can see, going into the 3rd and 4th quarter. That jumped up, actually jumped up, at least one of them jumped up, it looks like, a little bit. The legal consultations jumped up. We also started seeing a few more crisis calls in the 3rd and 4th quarter, and we do monitor those. We can get into some detail, not a lot of detail because of the HIPAA privacy regulations and what those may be, but they did qualify as a crisis call, and it was necessary to involve immediately a licensed counselor to assist those individuals with services. Next, you'll see your utilization trend since you went live in mid-2016. So 2016, as you can see, was a little bit low, but again, that's 6 months of utilization. We jumped up quite respectfully as well in 2017 and continue to see a positive trend in utilization through 2018, particularly for your EAP services. Continuing on, you'll see our website utilization on your next slide. That shows, in fact, really the line graph is pretty much in parity with what the utilization was in those that were utilizing the web. So while I'm suggesting the web being a tremendous resource for employees, we are seeing pretty respectful utilization of the web as well for certain purposes. So again, my bottom line, I think, with the utilization trend that we're seeing here, of course, we can always do better. It's not perfect, but it is fairly positive. Our book of business trend is around 3 to 5%, even north of that in many quarters. And your website utilization is some of the best that we've seen. So whatever's happening, whatever you're doing to promote it, keep it going. It's a great, the proof is in the pudding here. It's great, and we'll provide whatever resources we can. If there's more posters you need to put up in break rooms or wherever you want posters, if there's other communications, I know a lot of people get direct deposit, but we have paycheck stuffers, we have magnets, all kinds of things, promotional materials that we can use to further promote our services. Now let's get into what we wanted to propose, which is the Managed Behavioral Health Care Plan. As Aaron introduced, this is a case management and utilization management program that we've had tremendous success with other organizations, where when a person goes into a higher level of care, we define a higher level of care as a hospital being the highest level. A person could go in for a mental health issue, or they could go in for a substance abuse concern or addiction. And we would be resourced. We work closely with your TPA and insurance companies to ensure that there's coordination of care that way, and we're aware of people when they are in the hospital, that we have a licensed both clinician as well as a state licensed psychiatrist that gets involved in that person's care. And overall, we have found our utilization for a mental health disorder of about 5 to 7 days, length of stay down to 2 or 3 days. It's treated as a crisis, stabilize the crisis, and can we then look at them move to a lower level of care. We also manage through what's called partial hospitalization and intensive outpatient programs. Those are day treatment programs. Each have different days and hours of days of participation. We manage through that. And then to Madam Chair's question about getting them back into the community, getting them back resourced to a local therapist, if there's a local therapist, it's through that full continuum that we monitor and manage that person's care. So as you said, we don't get them out of the hospital and all of a sudden they're dropped back into an environment that may have led to a problem situation. So that's part of that case management, both acute intervention at the acute level, if you will, and then through the lower levels of care. We follow a number of quality measures in doing that. We want them in network. We try to work them in network. As I point out on the next slide, we follow all the necessary regulatory and accrediting organizations. We are what's called URAC accredited. That's the Utilization Review Accrediting Council for case management. And then we use a well-recognized medical necessity criteria in determining need. All of this is integrated in our own MIS system and medical records. We can communicate with others and coordinate with local providers if we need to electronically. I'm cruising quickly, so just stop me dead center if you need me to answer any questions, or we can certainly open that up in the end. I already touched on a couple of things on the next slide about having a licensed psychiatrist here in the state that does all our utilization review, the coordination of care, network coordination, and then the second to last bullet I want to talk a little bit about is the comorbid disease management. What we mean by that is, as you look at from our earlier presentations, the top 3 or 4 chronic illnesses of diabetes, heart disease, hypertension, and several others, studies are immense and robust with the relationship of behavioral health illnesses and disorders with chronic mental illness. And so many times the chronic, the mental illness side of it, or a behavioral health issue, is something, I'll call it as simple as a mood disorder, an anxiety or depression, inhibit a person's ability to really have effective treatment of, say, their diabetes, because they may be so depressed they don't become medication non-compliant or whatever it is. We are very attentive to that integrated approach in wanting to ensure that we're curbing the effect that one is having based on their chronic illness because of an underlying behavioral health illness that's going on. I attend a lot of different conferences. I was sharing with a couple of other people, and I've looked on a screen, and you look at what's happened in the last 3 years is major depression, anxiety, and bipolar disorder, suddenly the top 3 illnesses that we are finding that health plans are having to deal with now. Before, they never really looked at it, but the costs have risen over the course of the past 10 to 15 years to the point now that it is becoming very costly to have to treat people for these behavioral health concerns, unlike they were recognized in the past. You throw an EAP on top of that, and a lot of the EAP is getting in early before something becomes so dramatic that it has to kick into the mental health benefit. We don't get into serious mental health treatment in the EAP. It does become part of the mental health benefit, but a lot of times we're curbing that by the EAP impact early in a person's course of some type of behavioral health or substance abuse concern. That's my editorial for the day, by the way. I had to get that editorial in. I was impressed earlier. By the way, we did not see with our health plan partners, a behavioral health disorder is one of the top 3. I'd like to believe the EAP was impacting that, but I don't know. I'd have to dig into the data. All right, I'm going to bounce past that slide a little bit and just show you some data here. I already talked about leveraging the EAP on the front end, reducing length of stay, And recidivism, that's a person going back into care continuously. They go back into their environment, Madam Chair, and all of a sudden they decompensate again or whatever might be happening, and they end up back in the hospital again. We want to avoid that readmission type of thing. And then, of course, early identification and intervention. Here's a couple of statistics just to round this out. Up to 70% of visits to a primary care practitioner or medical complaints that actually stem from some type of psychological disorder or factor in their lives. And that anxiety and depression, as I mentioned earlier, are among the 6 most common conditions seen in a family practitioner's office nowadays. What about at the employee level? What's the impact on cost to you in managing employees and managing employee-related costs, presenteeism, productivity, and the like? 60% of employee absences are due to some type of psychological condition. Depressed employees are 3 times more likely to miss work than those that are not, and also have 1.5 to 3.2% more short-term disability days in a 30-day period than other workers. So just a couple of statistics to throw out there. Again, combining your managed behavioral health program with your EAP and getting on top of that decreases absenteeism, workers' comp claims, tardiness, and all those things that we struggle with as employers day in and day out. And you do see statistically significant increases in productivity, presenteeism, how they're doing and presenting at the workplace, productivity, as well as morale. Summary in your pricing right now under your succession model, as you're probably aware, you have a $1.44 PEPM is your PEPM. That is going to go up in July. We had a little bit of conversation earlier. We didn't actually activate that. I think that was supposed to be this year. It stayed at the 144 PEPM, but it is going to jump up in July, I think is what we talked about, right, Aaron? We talked already about the first responder and critical incident stress management. And then the program is an hourly rate. If we get involved in a case is referred to us to case manage, it's $200 an hour on the part of our folks to get involved with that. All right, I breezed through that real fast. I'm out of breath. I apologize. I know we were time limited, but any questions that I can address for you?
Nobody?
Do you have questions?
I have so many questions. I'm probably going to have to sit down with you after.
Let's do it. Absolutely.
But what I just kind of want to know for our purposes today, first of all, you kind of jumped over, you said the price is going to jump up from 144 in July. What's it going to jump to?
Okay, so Madam Chair, that was actually the point I was going to call out. This one's actually kind of an interesting one. The price went up last year.
It did. And
it went up from $1.44 to $2.26. Holman never adjusted their billing. So we caught it this year, and we were preparing the budget and said, hey, you guys never changed your rate. So they agreed to eat it for the year. So basically, they ate a year of lost revenue that we had agreed to, signed off on last year. So it's already in the budget. It's really not a change.
226?
We're just going to do it in the current year.
Okay. So like all the other things, what was it called for the diabetes?
Livongo.
Yeah. So do you monitor the success? I mean, do you have feedback like they do? Are the people utilizing it? Are they happy with it? Does it do what it says it's going to do? I mean, if I had a lot of time, I'd like to go back to that page where all the things you do, and it's a lot. Face-to-face time. And again, my concerns is the providers. We just don't have providers in this town for this kind of thing. And I mean, you've been doing it, so where are you sending them?
Well, I could get probably broader information about where they're actually getting care. I don't have that information with me. You're right. What's interesting with the utilization that you're having is we are finding providers that are accessible and they're accustomed to traveling to see a provider. Because there are times that we do register and we monitor any complaints where they say, hey, I couldn't find a provider, or a provider didn't get back with me, or whatever that might be. And we're finding that people are getting into a provider and in a timely way and are not having issues with whatever the drive time is or whatever it might be to get to that provider, as well as we will resource those network providers that are here locally.
So when you say
Foremost.
EAP, I mean, you're the first, so someone calls you, you're the first line, does it have to go to like another, you're sort of like the triage, and then you send them to another, like who assesses their situation?
Yeah, I didn't go through that very clearly. The telephone consultation is really what I referred to as a triage. We're gathering information.
Right.
What's the condition? Would it be considered what we call a routine, something that will take 5 to 7 days to get into someone and you'll be safe to do that, as well as other preferences that they have. We used to measure what was the reason they were calling. And we found that it was just skewed toward, we had 20 different categories. And then by the time they saw a provider and we received a claim, that naturally, and that does change because the provider now is diagnosing them. So now what we're doing is drawing out claims data to find out why a person is actually seeing a provider versus what the presenting problem was, as we call it, when they called in. So the first piece, I veered off. The first piece is a telephonic assessment with one of our care access specialists, and that's really an intake. And then they are assigned or aligned with a licensed clinician.
There it is.
To provide the care.
Where are those licensed providers that get to do their course of action?
Where are they?
Where are they? Where are you sending them?
I don't have that kind of detail. We do what are called geo-access reports, and I can actually get that information and let you know where all the providers are that are taking care of the patient, or taking care of the
Okay. And so the
employees here.
people going through this, do we find out if they were happy with it? I mean, it's kind of a limited thing, and when you talk about mental health and addiction, it's a long road. I mean, I just want to make sure that, you know, it's like something that sounds good and, you know, you can make that phone call, but then how do they go on with it?
Madam Chair, that's a good point. And ECA is not. I'm not sure what their internal satisfaction polls are, but ECA is not. That's something we can add on as a discussion point.
I'd like that. I would like to know. And out of those people in that pie chart that were using it, 44, were they first responders? I mean, were they just, I mean, how are we tracking like where they're coming from? And so maybe there's issues in certain, you know, parts of the county. You know what I'm saying? I mean, it's one of those things that I think sounds really good and it's all so well intentioned, but I just want to make sure that it's doing what it says it's going to do.
Well, we found, my spin on that is, to your first question, is we can get that kind of information because we collect that information and give that out globally. We can't really drill it down specifically because of confidentiality. We are very big on, you know, because of sometimes the stigma that's still tied to mental health issues or emotional problems or parent-child.
But you follow up saying, did we?
We can get some of that information.
I'd just like to know that.
But broadly, you know, give it to Aaron and his group, some of that broader information. As far as complaints go, are they getting into a provider in that? I'll tell you, the biggest means by which we hear if there's an issue is the person reports it back through their human resource department or something like that, and it's a telephone call saying, hey, so-and-so has not been happy with or had a bad experience with a provider or what have you. There is also a satisfaction survey in a grievance process that's on the website, which we publicize. So if a person calls us, and then we track what that is, we defer them to filing a formal kind of grievance, if you will, and then we follow up on that grievance. So there's a process to resolve that problem too. If there's a provider that just didn't fit or was problematic, we address that.
Because I know over the years we've gone back and forth with this mental health benefit, and I just want to make sure that it's doing what we promised it was going to do, right? And one more thing, so this HB 2502, that would only, in our case, apply to the sheriff's department.
I think in your case, because you have that separate agreement that I just, learned about. I can't speak to that.
Madam Chair, we built that in because it's essentially a no cost unless it's used item, but we have since become aware the sheriff's office has made provision for it, so we can actually delete it.
Oh, okay.
Okay.
Yeah.
Yeah, again, maybe another time we'll sit down, because I do have
Happy
a
to
whole
do
lot
it.
of questions.
Yeah,
Okay,
no problem.
Thank you. Anyone else?
So you're saying if a county employee calls, they are immediately assessed, and then within 5 days, they talk to somebody? Or is that assessment part of the 5 days?
Fair question. Our standard is that they will hear back from a provider that we've kind of matched them with within 2 days of their call. And that worst within 2 to 5 days. And then within that 2 to 5 day window, an appointment will be scheduled with a provider.
But that could be 6 weeks, 8 weeks.
It could be.
from
We
now.
wouldn't have a provider that's that far out. They commit to see people, within a week to 2 weeks on a routine case. That's not uncommon. Or sooner, depending on what the need is. Well, it could be later. It could be a lot of different factors that play into that. Fair enough. Anything else?
Okay, anyone else?
Negative.
No.
Thank you.
Okay, thank you. Okay, next one up is our health care reform update. Ooh, right on time also.
Thank you, Madam Chair and trustees. I'm Chris Marshall from Buck, and we'll be going over the accountable care updates. What's come up recently this year is that the 1095B and C forms, those when those were supposed to be mailed out, the original deadline was delayed until early March. So that deadline's passed, but it was delayed. They've also, though, kept the original deadline of April 1st for the electronic filing of those forms with the government. So that deadline has not been pushed back. So we just wanted to make sure that was clear. What's also come out is that the IRS has deferred assessing any penalties as long as you can show that you've made a good effort in place to present the materials on time to the employees and electronically. So I know there was a lot of fear around, and there's unanswered questions about certain things, but as long as you make a good faith effort, there shouldn't be any penalties with that. So the PCORI amount has been updated, so it will be $2.45 per member per year, and that will be for your plan what ends at the end of this plan year coming up, so the end of June of 19. Yes?
Can you explain what that is again?
The PCORI?
Yeah.
It's Patient-Centered Orientation Research Institute, so it's a fee that's collected each year by the government for research on different things. So it's a revenue generator for the Accountable Care Act. It went into effect in 2010, and this is actually the last year for it. So after this year, there will be no more PCORI fees to be paid. So you might remember a couple of years ago there was the transitional reinsurance fee, so that was for 3 years. That went away. So there's other revenue raisers on the books, and coming up in a few years there'll be the Cadillac tax. That's been delayed till the effective date of that has been delayed till 2022. But those are the only explicit revenue generators that are out there right now. So for self-funded plans. One thing that has come up recently is they are working on ways to make HRAs or health reimbursement accounts to comply with the employer mandate. Just as background, HRAs, it could be, I think of them as health retirement accounts usually because, but it's health reimbursement accounts. They're very popular with retirees because retirees generally are not held to the ACA restrictions, but you can have them for active employees as well. And what this is you can have it's a plan where each participant gets a group of money each year, and they're allowed to use that to go individually themselves into the marketplace to buy coverage. So you give everybody 5,000, 6,000, whatever that is, and then they go and purchase coverage on the exchange for themselves. Currently, that is not seen as something that qualifies for the employer mandate under healthcare reform. So there are not a lot of active plans to do that because the employer's not getting any credit for it. We're seeing, though, that there are rules starting to be proposed, and we're expecting this to take place with plan years that began on or after 1/1/20. And they're going to be set up so that you can integrate them with plans that are HRAs that do not deal with healthcare in the traditional sense. So you might have ones that do that are set up so that somebody can maybe get a critical illness policy or dental or vision or something like that, that's not going to qualify as the employer mandate, but they still want to have that. So it would be integrated with that. And the proposed rules right now would be that the plans you'd have to have only the HRA as an option. So you could not offer an active employee, for example, a choice between an HRA and a traditional healthcare plan if you want the HRA to count as part of the employer mandate. So if you offer them a choice, that would be to disqualify you from that. So as long as you offer an HRA and that's the only thing you're offering, and then there's other rules. So for example, if everybody in the same employee class has to be offered the HRA and it has to be the same amount, it would be subject to ERISA non-discrimination testing. So if you wanted to have an HRA, there are procedures in place to be able to do that, which will be, yes, to a question?
No, I kind of lost you. Look, I was
I'm sorry.
asking if anyone understands this. I know that this is just sort of technical stuff, so.
Yeah,
I just don't
it's
understand.
another way to provide health care where if you have, instead of offering a traditional plan where you're providing them the coverage and they get a plan with a deductible, copay, et cetera, instead you're offering them, you give them an amount of money and then they go purchase coverage by themselves on the open exchange. So they would go out and get their policy.
And this is what we were talking about years ago when it first hit us with if the Cadillac tax came in, which we kind of glossed over, that would be an option for plans like ours to just give people a set amount of money and say you're on your own.
Madam Chair, that's correct. That was one of the options that we looked at that time under the assumption, because those penalties on the Cadillac tax, if I remember correctly, are 40% mandated to be paid by the employer, but 40% of the dollar value in excess of the thresholds. So at that point, the county was, and I'm not sure where we're at today, but the trajectory was we would be above those, just a massive cost increase. So would it make more sense to then hand them an X amount of dollars, let them go buy their own coverage? That has since fallen by the wayside because of the constant delays in the Cadillac tax.
And with your expertise, is that ever going to happen, that Cadillac tax? And keep pushing it off.
Well, we can't, of course, say for sure. I would not be surprised if it keeps getting pushed back and is ultimately repealed before it ever goes into effect. It's designed to tax, it's designed to tax plans that are rich, but because it's based on cost, you could have blue collar groups that cost a lot more just because they're sicker on average. And they get penalized more than somebody that might have a richer plan, but works.
There were a lot of special interests that were mad about that.
Yes.
Yeah, okay.
Yeah, so I would not be surprised if it was, if it never comes to be. So, but if it does, as you said, yes, you could do, now you can do something like an HRA, and that would make, that would comply with the employer mandate, so.
Thank you.
Another recent big topic was, you may have heard that in Texas, there was a district court that ruled that since the employer mandate, or not employer mandate, the individual penalty for the individual mandate was voted out by Congress, that they decided that that was an essential part of the ACA. And without that penalty propelling people to fulfill the individual mandate, the whole law falls apart and is unconstitutional. They're saying it's a essential part of the law. In speaking from just a risk perspective, you want to have everybody that you can in the plan because you want to have the people that are not sick or on average or more healthy in with the people that are not as healthy to spread the risk around. So otherwise you have kind of what goes on in the individual market before you had healthcare reform. Generally the only people that sought out the insurance were those that needed it. So the court took this to be an essential part and declared that it was unconstitutional. So they said that the entire law was invalid. And then there was an appeals court that upheld that decision, but the decision was stayed, which means that while they agreed with the decision, they're saying, well, right now the law is still in place pending further review. And then when, going on to the next slide, so when that review happens, there's three possible outcomes that could take place. The reviewing court could agree and say that the entire ACA is invalidated, or they could agree but say, well, we agree, but what we can do is we can take out and make it severable the part where the individual mandate happens, and thus, even though we don't have the individual mandate, the rest of the law makes sense and is still constitutional. Or the court could overrule the decision. But no matter what happens, this is all within the state of Texas. I'm sure this is going to go to the Supreme Court no matter what they decide. And last I checked, there wasn't going to be anything coming anytime soon. So this is something to keep in mind. Maybe later this year something will come out. I don't have a date as to when that ruling will come down, but I'm sure it's going to be a very big Supreme Court case in the near future. If the ACA is ultimately invalidated or declared unconstitutional, what will the impact be for you guys? That will be that you do not have to offer any of the market care reforms that were mandated by the ACA. So your things like your coverage to age 26 or the free preventive visit each year, and then some of the essential services that have to be covered that maybe weren't before. So all of those things you would not be compelled to offer those anymore. And I'm sure there'd be other changes too, but those would be the biggest ones, I think. So. Just as an update, the IRS continues to look at if the employers are actually providing coverage. So there's two different types of the employer mandate that has to be followed. One is that you have to offer minimum essential coverage. And then the second is that that coverage must also be deemed affordable. So it's a certain percentage of income threshold generally is what has to be passed in order to be deemed affordable. And those penalties are being assessed right now. Last we heard, they're still working on years 2015 and 2016. So they're a little behind, but it's just an FYI. I know you guys all comply, but. And finally on the last slide, we've got the index dollar amounts. I always like having this. It's a handy reference chart. So, and shows over the years of the Accountable Care Act ever since it took place, what certain thresholds have been. So you've got the out-of-pocket maximums. So these are the maximum amounts that can be for self only and other than self. You have what the PCORI fee is each year, the TRF, what the healthcare FSA, and then the aforementioned penalties for failure to offer coverage or for failure to offer coverage that meets the minimum affordability. Anybody have any questions on healthcare reform?
Anybody? Okay, thank you. Next up, we have the review of actuarial renewal report and benefit change options.
So we'll go over the development of the trust's medical and dental plans here. The trend rate that we used for the projections was 7.5% for medical and prescription drug. This is a little lower than what we're seeing for other clients, but based on your recent experience, we felt it was warranted. We have been using 8.5 on a combined basis between medical, and when I say medical, in this context, I mean everything except prescription drug, because we usually see prescription drug costs running in double digits still for a lot of clients. But recent experience, we felt it was warranted to use a 7.5% trend rate, and we use a 4% trend rate for dental. Dental does not trend anywhere near as high as medical or prescription drugs. We do the analysis separate for medical prescription drug versus dental, and we use two different time periods in our analysis. We use the most 12 months, or the 12 months ending on December 31st, 2017, and then also the 12-month period ending the same time in 18. So basically calendar year 17 and 18. The next slide will show a chart of what the medical, and then on the slide after that, dental looks like for the development of the factors. We're recommending a rate pass for both medical and dental. The experience has been very, very favorable, especially the last 12 months, such that there is no increase that we're recommending. We will see, however, that if I did mention before how we used two different 12-month time periods. If you cherry pick the best one in each case and just use that and use 12 months instead of 24, you could have a claim factor that is a 7.9% decrease on medical or a 7.1% decrease on dental. We would not recommend that. We recommend using the whole 24 months and averaging them together. It just kind of makes things a little more smooth over the years, so you don't have the big ups and downs each year. So on the development of the medical rates, we've got the chart here. We've got in the first column of numbers is calendar year 17, and then next to that calendar year 18. So we have employee exposure months. So that means each person that's enrolled, they get credited 1 for each month. So if you were there all year, you would be 12. So you have roughly a little less than 1,000 people. Claims each year were just a little between 8 and 8.5 million, and then that we divide those out to get the per employee per month. We then have the adjustment to current benefits line. That is adjustments that are made due to plan changes from year to year. So as benefit improvements or other things are done, we adjust those claims so that everything's on the same level. As an extreme case, if we were to triple the deductible from one year to the next, that would have a big impact on claims. We'd want the new claims to reflect that, so we would have a big adjustment factor for that. Of course, the changes aren't that drastic that were done, so they're relatively minor here, but we do account for those. We then look at the trend rate, so we have the annual 7.5% trend, and we trend those forward 2.5 years because we've got calendar year 17 and we want to get to the experience for the new plan year, and then we also add 2 months for claim lag. If you go to the doctor, that claim is not turned around, submitted, processed, approved, and paid instantly. It takes time. On average, it takes about 1.5 or 2 months, so we use two months there. We then have a plan enrollment shift, and that is due to over time you have shifts in the population between the two medical plans, so between the high deductible, and then you also have shifts between family tiers and non-family tiers. So and over time, that the makeup of that group changes, and it's a slight impact, but we'd capture that here. We then wind up with per employee per month of $919 and change and $834 and change for the two different time periods. We average those together to get $877. So that $877 is then compared against your current funding rates enrollment on average. So if we take your current enrollment and multiply that times all the funding rates and determine an average, we would get $906. So we're projecting $877, and you're currently collecting or funding $906. So that's a decrease. So we're in these cases, unless it's a drastic decrease, what we tend to do is we recommend that you keep the rates flat for the next year. If we did look at just the 12 months for 2018, you can see it's $834. That would if you just use the most recent 12 months, you would have a 7.9% decrease, but that's only if you're using 12 months. Similarly, if you just use the 2017 data, you would actually have a 1.4% increase. But we're recommending a combined approach with all 24 months. So, any questions?
Anyone? No.
Okay. So the development of the dental rates, it's the same process exactly that we do for medical. The only differences really are haven't been any plan changes, and the trend rate is 4% instead of 7.5%. The lag is 1 month instead of 2. Dental tends to get processed and approved and paid a little faster than medical, so it's 1 month quicker. Here, though, the results are a little more even depending on the 2 years that we have. We have at the bottom, or not at the bottom of, or kind of in the middle of the page, I guess, the bottom of the projections. It's projected incurred claims per employee per month, and it's $56.94 for ending 2017 and $55.13 for ending 2018. So these get blended, and it's a weighted average of $56, and compared that to your current funding amount, it's $59.35. So that calls for a decrease. And you would get a decrease if you just use data from 17 or 18 in this case, but we're recommending that you just keep it flat. And the next slide just has the claim funding rates by plan. It has the current rates. Then if you, the next 2 columns of numbers are if you would cherry pick the best experience and use that only. So if you just pick the 12-month period that would benefit you the most by coming with the lowest funding rate, that would be the next 2 columns. But we're recommending the last 2 columns. So, and the percentage change, of course, is 0 since everything is flat. So, any questions? Okay, thank you.
Thank you. That's good news. Thanks.
So, Madam Chair?
Yes.
So at this point, what we've got on the schedule is a break, and then what we come back and do is we walk through what assumptions we've made, what recommendations we've made. Just as a little bit of background to that, when we submit the claims information to Chris to crunch, we pretty much don't have any idea what the recommendation is going to come back at. So we preload in a bunch of recommendations and have him price benefit additions and benefit cuts. Frankly, I don't expect you're going to want to do any of those today, but you never know. So we have a fairly involved spreadsheet depending on the direction the trustees want to go, both on those other options and on the recommendations we're making. And then we can just sit here, we'll crunch whatever you want to crunch. we'll polish any numbers we need to tonight, and then you'll do your final vote tomorrow.
Okay. Is everyone all right with that? Okay, let's do that. So you want to take maybe like just a 5-minute break? 10? You need 10? All right. 10.
I appreciate the size of this print.
Okay, we're back. And we're nearing the end here. The 2019-2020 budget building and benefit change options. Hit it.
Madam Chair, if I could, I'd like to do this one kind of as a conversation initially and then see what the trust wants to go. As I mentioned before, we've actually priced a bunch of options out, and we've got a spreadsheet with us that will dim lights from here to the Bill Williams River in terms of options, right? And what those are is if you have a target you want to get to. Traditionally, clients use those options when they've got a bigger increase than they can afford, and they tend to go towards the cuts. My guess is you have no need to go there, and I'm guessing, and again, I don't want to speak out of school, I'm guessing there's not an appetite for it either. So I'm going to be a little presumptuous and say, look, here's what our recommendations are. Our recommendations are do exactly what the actuary has said. Hold the rates flat, because you're not going to get away from the inflationary costs, just when they're going to catch up. And Mike has hammered this every year, saying you're being too conservative, and actually it caught up. We're right. We were conservative last year, which is a good thing. So just leave the rates flat. I would suggest the benefits, leave the benefits flat. You don't have a reason to. And then we have made some recommendations, and in addition to that, you may have some others you wanted. So our recommendations are, and it goes back, for the first one is a simple one, take the copay for the teledoc utilization from 25 to 10. Okay, that mostly affects the EPO plan. The reasoning is the more you can get people to steer that way and away from the ER, it actually saves money too on Chris's projection. I think that one's a no-brainer. Pardon me. The second one is this whole thing with the EAP. So on the EAP side and getting into the mental health substance abuse carve-out, where we take those serious issues away from American Health Group, and by the way, they're fine with it, and then move it over to Holman, there's no charge for that either, because you're already buying the EAP, and all we're going to do is take some of the dollars that we've budgeted for traditional, if you will, medical case management on American Health Group and slide them over. And I believe we said $8,000. We're going to slide it over for whatever may or may not appear, and we'll see how it runs for the year. So in our mind, those are neutral. The current plan has a fairly traditional benefit. It's limited on mental health and substance abuse, and we believe that represents a block to treatment and care. So the current benefit for inpatient stays is 30 days per year, but there's a lifetime maximum of only 2 confinements. So you're either going to hit 2 confinements or you hit 30 days, you're done. We're proposing to eliminate that and treat inpatient mental health and substance abuse as any other hospitalization. Okay? Second, on the outpatient side, there's an annual max of 30 visits. And again, we're proposing eliminating that. And then what would happen for mental health substance abuse for licensed practitioners is it would become a specialty copay, but they could go for as many visits as they want. And then the third component to that is for people who are accessing that care, voluntary basis, they could use Holman as a case management resource to get them to the appropriate level of care at an in-network provider. Because remember, there's no benefits outside the Blue Cross network in Arizona and Aetna nationally. The ballpark cost of that, based on Chris's assumption, annually is about $45,000. Okay? So that's our total set of, let me double check that, but that's our total set of recommendations. The final one that's really structural will come tomorrow, and Lynn, that's the one you just held up. We're not going to be looking at that today. We'll do that conversation tomorrow. But that's swapping out the prescription benefit manager. We did an RFP. We'll go into that tomorrow. We believe that will have savings, bottom line, after probably by the 18th month, because there's some gaps in there on how the rebates begin and end between the two firms. But we think there will be enough savings on that to actually more than offset the cost of the changes that we're recommending in the plan. We're thinking we'll see $50,000 to $100,000 bottom line savings by that switch without changing the copay structure. So we're recommending the change to mental health, substance abuse, the carve out on the case management, and the change in the teledoc copay. Thank you, and still holding the rates flat. I'd be happy to answer any questions or sit here and slice and dice on the computer as much as you guys want.
Question?
Madam Chairman?
Yes.
With no increase to the county or our employees, is that what you're saying with the recommended changes?
Madam Chair, Mike, that's correct.
I didn't know if we were discussing no changes or the trust absorbing any increases, but no changes. That's excellent. Thank you very much, Madam Chairman.
I have a question. So on this mental health thing, and you said, we used to offer 2 confinements, meaning 2 hospital stays or facility stays, and now you want to take that cap. How can you know that that's a cost to that? I mean, if you're giving it now unlimited, I know there's a lot of recidivism going in and out of these facilities, these spin dries, basically is what they're called. So how can you know that that's going to be $45,000, it's going to be a wash? I mean, is that what your history shows, or?
Madam Chair, actually, Chris could give you the methodology because his was the projection of the cost for the increase, what it would come to in the claims fund. The $45,000 actually came from Chris. I'm projecting, what I'm saying is that separate from him, that on the prescription drug, the switch and the PBM vendor, I think will more than offset that $45,000.
So you're mixing the 2.
Absolutely.
I thought they were 2 separate things. Oh, okay.
One is Chris, that's the expert. Mine is the back of the envelope. Hey, we've done this with other ones using this kind of a combination. That's what we saw. I expect that to carry through.
Right. But again, we have a county that has a very high addiction thing. So I want to make sure that you're comparing it apples to apples.
Madam Chairman?
Yeah.
Another question. Is there going to be an unforeseen impact for future years for that action? A substantial unforeseen impact?
That's an excellent question, Madam Chair, and the short answer is we'll never know, Mike, until we get there, because it's kind of like how many diagnoses of cancer will we get next year, or accidents. You just don't know at the end of the day. But I will tell you, just to add a commentary along those lines, if I may, I think what we have this year is an anomaly in terms of the claims experience went so well so rapidly. Without going into all the detail, we've seen a dramatic drop in the large cases. We only have about 30% of the large cases that we had at this time last year. We've had several people make what I would call natural progressions off the plan. They changed employment. They were large cases. They went away. 2 in particular came to almost 600,000 between them. And then just beyond that, we have, as of today, knock wood, we have not seen the large cases. So we're just taking advantage of the fact, in my mind, that we caught a break, right, and just keeping it stable, and then we'll probably move back into the natural cycle in the future.
The only thing I'm not sure about is the unlimited confinement. I think that's a hornet's nest you're opening up there. I don't know.
And Madam Chair, I don't have an answer. It's a risk. I get it. The recidivism on that, or the failure rate is pretty big.
Especially if it's, somewhat inexpensive or free. It's, it's something people will go to when they, it's better when you have a little skin in the game. So I don't know.
Madam Chairman, I would have to agree with you, and that's why I rose the question. What is it going to cause in the future? Well, we don't know. That's not a great answer, but it's a truthful answer. I'm not criticizing at all. But I think county, just my gut feeling is county coverage should be finite. It shouldn't be infinite and forever. And I think that opens us up to potential future liability. Thank you.
And then we see that it has been so successful, or it's what we need, I think, to start with that, since we're making all these changes, would be just more prudent.
And again, for information purposes, it's not, the 2 is of what's in effect today.
You're right.
So that lifetime maximum is in today. I mean, we could do, as an alternate, we could do and just get rid of the 30-day limit, right? Because you have 30 days or a lifetime limit. And as challenging as it is, I still would advocate for making the change because of 2 things. One of them is that we're only providing care in the Blue Cross network. So we know if they do go inpatient, we're going to get the discounts because they're going to be we don't provide any coverage out of network. This will not get rid of that, okay? And then secondly, and this is the hard part, when you think about it, I get the addiction thing, I get the failure rate on addiction, but we have a very similar parallel in the medical side when we get recurrences of cancer. Okay, you can argue it, But the reality is cancer comes back and we don't cap the number of days that somebody can be in any setting when they're treating cancer, cardiac, any of those other conditions. Tough one.
I don't really see it as a fair argument, because there are other ways to cure addiction than, with MAT or in treatment things. I mean, there's other options.
But if you would like, on that note, if you come to consensus as a trust, what we can do tonight is we can look at something, I can look at something with Chris, come back with a different number tomorrow. The issue would become we would not go to mental health parity. We would not go to full mental health parity, so because we'd have to continue to elect the waiver with the federal government. We would have to come up with some kind of a hybrid benefit in the meantime. And like I said, I could huddle with Chris and Mike tonight and see if we can come up with something that would kind of address some of the issues about the unlimited element of that.
Right, and then we could, go home and sleep on it, and maybe we'll have other things that we want to ask you about it, because it was just kind of dropped on us, and I have to think about it.
Madam Chair, you're in a great position, because frankly, either way, you're not going to do anything that's going to cost more, and I think you're going to come back at a flat rate anyway, so it's just how do you want to slice this particular element?
And again, it's for anyone watching this, it's not that we want to take, it's also for what's best for not only the county, but for the employees and for people in general, because sometimes there are unintended consequences of trying to do, something considerate and compassionate.
Madam Chairman, and just to beat that dead horse, we're also insuring kids, and, I could see the county being responsible forever for the care and treatment of an individual, I would assume. But if we are, I did have another question. Today it was brought up that Blue Cross was also offering what Aetna was offering for out-of-state treatments. What's ECA's recommendation on that?
That's an excellent question, Madam Chair. Mike, we don't know yet, Mike, because Blues hasn't done their pricing, so we don't know what their charge is going to be for out-of-network. And then second, our assumption is we're going to look at that. We don't know, and Chris will wind up doing this work, is we don't know how the network discounts compare between the two for the out-of-state coverage. So it'll be a multi-part review, which is how do the networks compare in terms of doctors, hospitals, whatnot, and then how do the discounts compare in the areas where the majority of care is being done. And then finally, on the cost, we're paying Aetna a cost per employee per month for the out-of-network. Blues has a different pricing structure. So by the time you net out those charges, which one has the greatest likelihood for savings? So we won't have an answer until next year, because they're not even going to offer it until July of 2020.
Madam Chairman, so we're going to stay with Aetna for this year. That's the recommendation.
That's correct. Aetna for the other 49 states.
Madam Chair, I have just one question, and that's, in view of the fact that, we're covering children until they're 26 now, what's the success rate of somebody that's in a substance abuse program for 30 days? That can't be a high success rate, is
I would have
it?
to defer to Mike, Madam Chair. The question is, what's the success rate for somebody that's on a 30-day inpatient stay for substance abuse?
Particularly with children or adolescents? Particularly with children and adolescents, the success rate really is there's a lot of different rates that are out there. I think part of it is, you talked about that, the biggest part of it is 30 days is a magical number. A lot of people, 30 days is a historical treatment model. Very few people are in a 28 to 30-day program anymore. A lot of it's based on medical necessity and step down into lower levels of care. And we talked about the different day treatment programs, both the after-school programs for children as well as the partial and the intensive outpatient programs. If they're in consistent care, that recidivism goes down as long as they've got a network, positive network that they're going into and have continued aftercare. But very few anymore are in kind of a model 28 to 30-day program in a managed healthcare environment. It's really based on medical necessity, is what we've experienced. And it's good. It's good if they've got continued care and they're discharged into the right environment. A lot of factors that go into that. Not a direct answer.
We
to
do
your
have
question.
28-day programs in this county. And what about MAT? I mean, is that something, the medical assisted treatment, is that something that Holman encourages or advocates for? I mean, that's all part of it, but everyone here should know that's now all part of the accepted treatment in substance abuse is, treating it with other substances. Which is, something we can debate about, but that's part of it. And then you're just still stuck, So, you're just keeping the cycle going, and that's my fear of all of this, that we'll just never end that cycle.
Yeah, to answer your first question about Holman and MAP programs, yes, we're supportive of MAP programs. Yes, ma'am. Pardon
It
me?
used to just be methadone, but now it's accepted for pretty much everything.
But yeah, exactly. I mean, there's a lot of different programs too. Suboxone treatment anymore, really kind of replacing the methadone in different environments. Suboxone, Subutex, particularly for the opiate addicted population, absolutely.
Okay, so I think what we came up with was you're going to come in with tomorrow with some other numbers and choices for us to see.
We will work our magic tonight.
I know
Madam
you
Chair.
will. Thank you. Does anybody have any questions? Do you have anything? Yes.
Thank you. I just want to make sure that I'm understanding from the numerical piece of this. So on the memo and then also on, it's not numbered, but the page that has the draft budget, and it's got 507,000 number on the side column. You know what I'm referring to? It looks like this. So it shows a bottom line, a grand total budget of 13.6 million.
Yep. Okay, Coral.
Okay. So it referred to an increase of 507,000, and most of it is related to the specific stop loss and the aggregate stop loss. But it's really not an increase, is that correct?
Yeah, well, that's correct. I mean, at the end of the day,
sure.
let's distinguish, because what we're saying is that we believe we can hold the rates, because the actuary is saying you can essentially cut the funding factors, okay? So we are projecting that certain fixed costs will go up, but that we believe that given his funding factor, the ability to cut the funding factor, we can absorb those increases within the existing rate structure.
Okay.
That makes sense?
Yeah, so we would stick with, because on a very preliminary basis, but you arrived at this number and we arrived at basically the same number, 13.5 million, which was the same as last year. So we're within a very close margin of each other.
Always makes me
I just
happy
wanted
to
to
be
make sure it
close.
wasn't supposed to go to 14.1.
No.
Okay.
Always glad, Coral, when your and our numbers match up. It's always a good day.
It is a good day.
All we're saying is we think there's enough room in the rates, we can absorb the increase,
If it
increased
happens.
costs and keep the rates
Right.
flat.
Yep, I agree. Thanks.
Okay. Do you have anything for us?
Madam Chair, unless you want, like I said, unless you want to start pricing other stuff out, I mean, our assumption is no. I think this one's almost too easy.
Yeah, well, this has been a great meeting, and looks like we did a good job this year, and we're going to be, and for people watching, going to have more benefits for the employees going forwards, no rate increase, so it's all good.
It's all
Just
good.
have a few little details to iron out.
That's correct, Madam Chair.
Okay. Well, unless there's anything else, yes, Sam?
I just want to say that, and that's, I was incidental in getting you appointed for the school board EBT, because you've always done this such a great, thorough, and thorough job to do this. And this, I had to commend you on this year, because all the way through, I've been trying to find questions to ask, and you guys have got this thing laid out slightly different, but slightly a whole lot better than normal. And I just wanted to commend you on doing such a great job at that. So.
Thank you.
Then if there's nothing else, we'll call it a day. And we'll see you back here tomorrow, same thing, 8 o'clock upstairs, 8:30 start time.
Correct, Madam Chair.
Fantastic. Thank you so much.